Over there.
Where? I can't see it.
Are you sure?
Oh, I see now. It's a castle, a big castle.
His name is Romeo and Montague, the only son of your great enemy.
Look over there.
Where?
There. It's the heart.
The patient has required an artificial pacemaker to directly send electrical impulses to her heart.
Do you see anything else?
A lion.
What else do you see?
I see.
I see.
Phil.
I see.
أنا شايفة.
Je vois. I see.
I see.
Working on, we see her future. Our vision is a better and healthier.
World have an unmet needs for contraceptives. At Organon, a large part of our efforts is dedicated to treating women's health concerns such as infertility, as well as expanding access to contraceptives and family planning services, which are critical to achieving the empowerment of women. Our portfolio of over 60 medicines across our biosimilar and established brands pillars focus on fertility and contraception besides other healthcare concerns which impact women. In fact, over the past 20 years, organ medicines have been successfully used to treat infertility. While great strides have been made in advancing reproductive health, access and education remain critical barriers that have been compounded by COVID-19. At Organon, when it comes to her reproductive health, we are committed to helping her make informed decisions to achieve a better and healthier every day. As such, we continue to invest in reproductive health with a view to expand our portfolio and identify new treatments, diagnostics, and devices built around her needs. And critically, we understand that affordability in the current healthcare landscape is key. That's why we are committed to developing and ensuring access to more unique established brands and biologic therapies that treat a variety of serious diseases and conditions, including biosimilars, fertility, contraception, bone and pain, cardiovascular, and respiratory. In fact, looking to the future, we are ready at Organon to build on a solid foundation of deep heritage and early innovation to grow all our products in partnership with key stakeholders and local regulators that plug the gap in unmet healthcare needs for women and her family members. But we need platforms such as OSCAR, in which we can extend knowledge, share our expertise, and ultimately create new partnerships in the interest of advancing healthcare. We are very proud to kick off OSCAR version 2 and looking forward to a very fruitful 2-day sessions. On behalf of Organon MENAT leadership, we would like to thank you for joining us today, and I thank the team behind this special event. Enjoy the sessions.
What do you see? Over there.
Where? I can't see it.
Are you sure?
Oh, I see. Now, it's a castle, a big castle.
His name is Romeo and Montague, the only son of your great enemy.
Look over there.
Where?
There. It's a heart.
The patient has required an artificial pacemaker to directly send electrical impulses to her heart.
Do you see anything else?
A lion.
What else do you see?
I see.
I see.
Pero.
I see.
أنا شايفة.
Je vois. I see.
I see.
At Organon, we see her future. Our vision is a better and healthier day for every woman. We believe by listening to women and focusing on innovations that address their unmet needs, we can realize a future as unlimited as her imagination. Now is the time to rewrite the story on women's health. Organon, here for her health.
What do you see? Over there.
Where? I can't see it.
Are you sure?
Oh, I see now. It's a castle, a big castle.
His name is Romeo and Montague, the only son of your great enemy.
Look over there.
Where?
There. It's a
The patient has required an artificial pacemaker to directly send electrical impulses to her heart.
Do you see anything else?
A lion!
What else do you see?
I see.
I see.
Pero
I see.
أنا شايفة.
je vois. I see.
I see.
At Organon, we see her future. Our vision is a better and healthier everyday for every woman. We believe by listening to women and focusing on innovations that address their unmet needs, we can realize a future as unlimited as her imagination. Now is the time to rewrite the story on women's health. Organon, here for her health.
Hello. Good afternoon.
But you did excellent. I would like to ask the audience to share their question and comments on chat so we will be able to share them with our esteemed panel. Now, my next question is to Dr. Ashraf. We do know that asthma control worldwide is suboptimal. So how does it look like in the Gulf region, and what are the contributing factors for this suboptimal asthma control?
Assalamu alaikum. Good morning, everybody. Dr. Fatma, a pleasure to be with you today, and I'd like to thank you and thank Organon for inviting me. And I have to say that the answer to this question is not much different than other parts of the world. And I'll try and share my screen here. And I'll share with you an outcome of a survey that was conducted in the Middle East, including the Gulf countries. And I was lucky to be a co-author in this same survey, is the name of the survey. And this included a survey for asthmatics in the region, in the Gulf region. In this study, I will include the data that was including patients from the Saudi Arabia, UAE, and Kuwait. And Dr. Nasser Bahbahani and Dr. Majdi Idris, who's with us here today, were the co-authors in Kuwait and Saudi Arabia. One thing that we learned, Dr. Fatma, about this study and my audience is that it was mainly on adult population. The most impressive thing is what you see here about the tobacco smoking. Did you imagine to know and learn that tobacco smoking in an asthmatic household in the Gulf is between 60 to 85% in Kuwait, 50% in UAE, but 61%. And this is very relevant in the next few slides. Also, what doesn't make sense to me is to learn that when those patients were asked about their medication, the proportion of people who said that they take both the controller, which Dr. George's track 2, when he was speaking about track 2, for example, daily control and quick relief, or track 1, 80% in general, 87 in Saudi Arabia, 66 in UAE, and much less actually in Kuwait, reported that they're taking daily control plus quick reliever. So you'd expect if patients are taking the right medicine, you see a good asthma control. And what was the result of asthma control? If you look on the graph on the pie on the left-hand side, you'll see the patient perception of asthma control, the pink and the blue color. So 2/3 roughly of patients thought that they are either well controlled or completely controlled. But when you check them using GINA guideline, controlled controlled asthma as per GINA guideline almost does not exist. Those 2/3 were only in the best case scenario partially controlled. And then we went on and we analyzed this pink fraction, the completely controlled 77 patients, which is 17% of the asthmatics that were surveyed. And what did we learn? We learned that 2/3 of those that thought they are completely controlled, 2/3 of them were actually only partially controlled using GINA guideline. And 22 of them, almost 1/3 of them, were actually not controlled. Controlled asthmatics as per GINA guidelines did not exist. And when we also learned that in the Gulf, there is a big contribution to asthma uncontrolled days when patients are outdoor, as opposed to indoor. This is on the left-hand side, where you see that patients, regardless of what treatment they're taking for asthma, their uncontrolled days are much higher, and the number of patients that have uncontrolled bad days are usually those patients who are outdoor. And this is where I said tobacco smoking. In the Gulf region, 65% of asthmatics thought that tobacco smoking is trigger for their asthma, changes in weather in 50% of them. And how much is this impacting on their life? Sport and recreation, normal physical exertion, social activity, sleeping and daily activity. Big proportion of patients, pink being a lot of impact on these activities. 15 to 30% of patients have impact on these outcomes if they have asthma. And we also learned more about how is asthma managed in the Gulf. We learned, for example, 70% of asthmatics are diagnosed by GP. And this is not the case in Saudi Arabia. 70% in Saudi Arabia are diagnosed by pulmonologists. It's 50-50, between 50% being pulmonologists and 50% split between GPs, internal medicine, and pediatrician. And when it comes to follow-up, the same case. We also learned that only 1/3 of patients per lung function in the Gulf, despite the fact that we know we have easy accessibility to spirometry. And peak flow meter is almost unheard of in this area. Maybe 6% of patients heard about peak flow in Kuwait and 20% in UAE. And the harsh question was to learn that 1/3 of our patients, at least, would stop their medication for at least a week over the past 12 months, and they use the quick reliever on average 2.2 times. And when we ask them, why are you quitting those as medication? It is the subjective feeling that they don't have symptoms, and their symptoms, or if their symptoms are not frequent and it's not bothering them. So while you would think that asthma control would be better, it's not better, despite the fact physicians, whether they're GP or specialist, prescribe medicine for them. Our patients, 1/3 of them stop medicine for 1 week. I think future research will be really vital to know. Do they really stop for a week only, or do they continue stopping the medication for the rest? We already know from other international studies that only 12% of asthmatics will be still taking their asthma medication after 12 months. So persistence is also a factor that we have to look into. So that's really how our patient, Dr. Fatma, deal with their asthma symptoms subjectively, and this is how they use their medication. Thank you.
Thank you, Dr. Ashraf. Very clear. I think it all has to do with the compliance, which is a big, I think it's a big issue in our region, especially pediatric population. Okay. My next question goes to Dr. Mahmoud Al-Watanouni, head of chest and ICU department in Egypt. Now, SABA has always been an integral part of asthma treatment since many years back. However, according to the latest recommendation from GINA guideline, it should not be used to treat asthma. What do you think the reason behind that? And if you can share some studies that have led to this latest recommendation in GINA?
Thank you so much, Dr. Fatma, and thanks for Organon for organizing this valuable meeting. And thanks for my esteemed colleagues for their nice presentations. Actually, I'm very happy with this question because as a professor of pulmonology in Cairo University and actually I'm head of a lot of ICU, including the University Hospital ICRS Pulmonary ICU, we see a lot of patients that are not controlled. As Dr. Ashraf just mentioned and stated before, they think they are controlled, and they are one of the victims of fatal asthma sometimes. These patients that seem to be well controlled. And was our problem actually, that's about it. Yeah, okay. These patients actually are apparently mild asthma and are at risk of a very serious adverse effects. They had symptoms less than weekly in 3 months, and they are 30 to 37% of them with acute asthma, 60% of patients with near fatal asthma, and 50 to 20% of adults dying actually of asthma. This is very serious. Yani, patients like in this era, with a lot of medications, with a lot of science, with a lot of hospitals dying of asthma, this is really very bad. The most important thing is the inhaled SABA. For centuries, maybe 5 centuries, it has been the first line of treatment. You've got asthma, you've got the reliever medication, terbutaline or salbutamol, and this is the complete control. I'm controlled, that's good. I don't need anything. I don't need a pulmonologist. Inhaled SABA has been first treatment for the last 50 years. These dates from an era when asthma was thought to be a disease of just bronchoconstriction, not an inflammation. Patient satisfaction with and reliance on SABA treatment is reinforced by its just relief of symptoms, its prominence in ED as nebulization of SABA and hospital management of exacerbations, and the patient commonly believe my reliever gives me control over my asthma. I don't need any additional treatment. So, the background to the changes, the regular or frequent use of SABA is associated with adverse effects. First of all, the beta receptor downregulation, the decreased bronchoprotection and rebound hyperactivity, decreased bronchodilator response. So, we downregulate our receptors because we're not using a controller. It's just a SABA, our short-acting beta-2 agonist. Increased allergic response and increased eosinophilic airway inflammation. The higher use of SABA associated with dispensing more than 3 canisters per year is associated with the presentation in emergency department, and dispensing 12 or more of canisters per year is associated with high risk of respiratory action. So, since 2007, GINA has been actively seeking interventions for mild asthma to reduce the risk of related exacerbation and death, and to provide a consistent messaging about the goals of asthma and treatment and the control of exacerbation across the spectrum of the asthma severity. To avoid establishing the patient reliance on SABA early in the course of the disease, GINA emphasized that the poor adherence as a modifiable risk for exacerbation. And this is the most important thing that we're talking about in my question today. This is the role of the professors to treat their students, to teach their students and their followers and their patients that the controller medication should be all through. So when the reliever is SABA, poor adherence with maintenance control, makes the patient risk to the SABA-only treatment, and the GINA members repeatedly sought funding for randomized control studies as needed for ICS for the risk reduction in the asthma control. In the meantime, GINA conventional criteria for initiation of ICS. During the preparation of 2014 GINA revision, we identified no evidence of recommendation to withhold ICS until symptoms were more than twice weekly. And the first mild asthmatic patient should take SABA only when needed. And that was till just a few years ago, okay? The GINA found no evidence to support step 1 SABA only recommendation. The lack of evidence for SABA only treatment contrasted with the strong evidence for the effectiveness of treatment. In 2014, as an interim safety measure, GINA restricted SABA only treatment to patients' symptoms less than twice a month and no risk factors of exacerbations. So, in a review, there's a SIGMA study determined that if needed budesonide formoterol is superior as needed to erbitalin at number 1 for enrollment and the run-in in the visit number 2, and then the randomization for the next 52 weeks. As needed budesonide formoterol is superior to as needed terbutaline in achieving asthma, but inferior to maintenance of budesonide in mild asthma. So when you use the budesonide maintenance, it's the superior control. If we use the budesonide formoterol as needed, it's good control, but less superior than budesonide maintenance alone. If we use terbutaline as needed, just as I told you, it's the least control. As needed budesonide formoterol is non-inferior to daily budesonide in the time of first moderate to severe exacerbation. The SIGMA-2 budesonide formoterol was non-inferior to budesonide maintenance therapy for severe exacerbations. So it will be almost the same curve. This is not non-inferior study, okay, the SIGMA-2. The change in bronchodilator FEV1 from the baseline, as we see, we have more liters here in the budesonide maintenance, more than budesonide formoterol as needed. In budesonide maintenance was statistically significant better than budesonide formoterol as needed, but below clinical significance. It's not highly clinically significant, statistically significant. So for safety, GINA no longer recommends SABA-only treatment for bronchial asthma or mild asthma. The decision was on SABA-only treatment increased severe exacerbations, and that adding any ICS significantly reduces these exacerbations. GINA now recommends that all adults and adolescents with asthma should receive symptom-driven or regular low-dose ICS containing controller treatment, that's the ICS, to reduce the risk of serious exacerbation. And thank you so much.
Thank you so much, Dr. for sharing these clear studies. Now I'll go forward with my next faculty member, our dear colleague, Dr. Majdi Idris from Saudi Arabia. And I would like him to share his experience and perspective when or which patient population would benefit more from adding on montelukast. Dr. Majdi?
Can you hear me?
Now we can hear you, yes.
Okay, thank you so much. So I'm going to be talking over the coming 5 minutes or so about the specific patient's phenotypes with really asthma. But we need to understand the concept of the multiple inflammatory pathway in asthma, looking for leukotrienes and cytokines, interleukins, and that each one of those has its own role. We know that now each one of those inflammatory mediators have a different really endpoint and probably different medication. And we know that there is synergistic effect between montelukast and beclomethasone in controlling inflammation in a mild asthma patient. That's not the case when it comes with the LABA, when it comes to the level of anti-inflammatory basically control. So clearly that using more anti-inflammatory medication, you would control the level of inflammation in the lung better than really monotherapy. And this was a very nice study by David Price and his team looking at what happened in those patients who are not well controlled on low dose of steroids. Should we double the dose of steroid, or should we add actually montelukast in order to have this multiple inflammatory mediated pathway controller? So in their patient, they really randomized them into two arms, montelukast versus budesonide and placebo. And they found that in those patients who were not controlled in low dose of steroid, doubling the dose of steroid versus keeping the dose low and adding montelukast will give you probably similar effect when it comes to the asthma control, the lung function, and the night symptom as well. Both arms did very well. However, clearly that when they look at subgroups, and they did subgroup analysis for those patients who had coexistent rhinitis, it was very clear that really adding montelukast to a low dose of steroid was better than doubling the dose of steroid, again emphasizing on this the single airway or the united airway basically problem with the upper and lower airways, and that we need probably to use dual anti-inflammatory medication to improve the outcome in those patients. What about LABA? All we know that LABA, we heard from the guideline that really LABA now is the preferred study. This was by Nelson comparing adding LABA versus adding montelukast to patient with uncontrolled asthma on low dose steroid. And then the lung function, it was clear that adding LABA was better. However, when we look at the inflammatory endpoints, such as exacerbation, you would see clearly that there was no clear difference between the two arms, whether you add LABA or you add montelukast. And the IMPACT study that was published a few years ago, trying to look at this in more carefully. So those patients who were not adequately controlled on low dose steroid were randomized to either add montelukast versus adding salmeterol. And what they found, again, when you look at inflammatory endpoints, for example, really asthma exacerbation, it was clear that both will do eventually very well in controlling exacerbation. Nocturnal symptoms, which is another inflammatory endpoint, was really the same when it comes to adding montelukast or adding salmeterol. Of course, when it comes to lung function per se, we all know that adding LABA was better. However, very interesting observation found that when they look at the eosinophil count in the sputum in those patients, they found that having this kind of dual anti-inflammatory medication did reduce further the eosinophilic number in the sputum, while those patients who were on LABA, actually they had a little bit of increase, and that's probably what we call the hidden inflammation that could be masked by adding simply bronchodilator, despite the fact that it might have some synergistic effect with the inhaled steroid. So my take-home message, I think we need all to understand that when we deal with asthma patients, we need to look at specific patients who have specifically inflammatory endpoints, such as night symptoms, they have frequent exacerbation, and understand this kind of the really multiple pathway of inflammation, really including cytokines, interleukin, and leukotrienes. And we know from very clear study that steroid itself, by itself, does not really influence the leukotriene mediators. And specifically speaking, if you have both allergic rhinitis and asthma, or those inflammatory mediator or really endpoints, we think that really adding on montelukast will be of great value in those patients. Thank you very much.
Thank you, Dr. Mirti, for sharing this valuable information, very clear. My next question is to our dear colleague, Dr. Riyad in Bahrain. From your perspective and referring to the situation we see in our region, What are the patient educational needs, and what are the digital solutions needed to bridge the gap in asthma control?
Thank you very much, Dr. Fatima, and thank you very much for my colleague for their nice presentation. And now that you have heard about managing asthma from the top authority in the region, you must have been realized that the key word in asthma management is probably is the word of control, and it's a big gap that we need to address. Having more than 2/3 of our patients either partially controlled or completely uncontrolled is really a big challenge. And in my opinion, there are many factors that has led to this state. And the two words that I might go through to answer this question is by we are knowing a lot about asthma, and there is still some more to know about asthma management. The two factors that might have led to the asthma management and the gap that we have to fill is probably we are dealing with different phenotypes, and the other word is because of the adherence. And what I mean about the phenotypes now, asthma is not a one disease. We know a lot about the phenotypes, endotypes, the comorbidities that might also present in asthma patients. You have the T2, the non-T2, and within even each group you have sub classification into the allergic asthma, eosinophilic type, and so on and so forth. So knowing what we are dealing with in asthma will enable us to better treat and control the asthma. The second reason, in my opinion, is the low adherence, and that might be due to so many factors. Factors related to the patient himself. For example, patients might have physical disorders or cognitive difficulties, psychiatric comorbidities. The age is also a factor, lack of knowledge, expectation, and also the social and family support. And there are factors that might be related to the disease itself, being chronic disease or sometimes with stable symptoms or even no symptoms is also could contribute to the adherence. Now, the treatment itself could be also a major factor. When you are using a high number of daily doses, for example, there is an adverse effect for the treatment, complexity of the therapeutic regimens, the easiness of the use of the treatment, cost and healthcare coverage. These are factors that might also affect the adherence. And now one important factor that we always have to keep in mind is the doctor-patient relationship. So the poor the relationship, the poor the adherence will be. And the lack of communication between these two will definitely be impacted in the adherence. One thing that we keep always classically teaching our patients with is the personalized asthma action plans. And this is something that has to be taught to all patients. All of them should receive a self-management education, including written action plans, which should be easy to understand. It has to be individualized, and the trigger avoidance has to be addressed. And every single patient who have admitted with asthma, for example, has to undergo a review of their self-management skills, and the clinician should ensure that the action plan is in place, and also make sure that the patient knows what to do in the event of their asthma deteriorating. This is something that we have to keep always in mind so we achieve a good control. Now, in real life practice, we have so many kinds of treatment available in the market, right? So we have lots of inhalers available. So which one to use for which patients is also a challenge. Teaching them the different modality of inhalers is also another challenge. So we always have to keep up in educating and following the evidence which medications is suitable for which patients. I'm sharing with you this study which compares the two famous inhalers that we are using in our practice. The one is the dry powder inhaler and the meter dose inhaler. For example, just by simply teaching the patients to inhale fast when they are using the dry powder, have significantly improved the rate of exacerbation and the quality of life. The same thing when we are using the meter dose inhaler, we always tell the patient to inhale slowly. So just emphasizing in the technique of the inhaler will be affecting the outcome. And the outcome might not be only the asthma control, but it might also lead to mortality effect, as this Kaplan-Meier curve showing. If you just follow the red line here, which represent the poor adherence, the poor technique, they are associated with higher rate of death. So controlling asthma and emphasizing on adherence be also a mortality factor. Now, one of the factors that we always try to teach and also assist when we are dealing with asthma patients is the ability of the patients to have their inspiratory flow, the peak inspiratory flow. Because we know that around 1/3 of patients might have suboptimal inhalation efforts, and that will lead to worsening of their symptoms, and more importantly, leading to higher severe exacerbation rates. Like in this study, it shows more than 70% they have severe exacerbations. And this is because we have different inhalers with different inspiratory flow requirements, and we have to understand the mechanism and the technique of each and single inhaler. Now, regarding the digital part, I think there are a lot of current and emerging technologies in asthma, and we'll start seeing now smart spirometers, which are linked to the smartphones. You have the patient himself assessing the asthma severity by doing the spirometry and linking it to an application. The same thing with inhalers that might be also linked to a module that not only reminding the patient to use their doses, but will also teach the patient whether they are using it correctly and properly, about the volume and how much inspiratory flow that they have to make. And these kinds of tools will enable us to improve the control, the adherence, and it also will be a predictive factor for exacerbations. So, for example, the number of inhalation that has been used, or the trends, or the volume will be also a predictive factor to know which of those patients might progress into exacerbations. Now, you might be started to see that a lot of companies are interested in this digital inhalers, and in combination with the digital partner and device platform, we will start to see, hopefully soon, a lot of inhalers which are having the modules and related to the smart devices, and that will have a great impact on patients' control, especially in the field of asthma. I hope I answered the questions, and I'm ready for any comments or questions. Thank you very much.
You did, Dr. Riyad, and I loved the slide on all the shampoos, ladies' shampoos, in your presentation. Thank you so much. I would encourage again our audience to share their question on the chat board so I can forward it to our speaker. However, we have a few questions here, and I would like to start with the first one addressed to Dr. Majdi. Do you recommend prophylactic treatment of asthma and allergic rhinitis in case of months with high respiratory infection seasons?
Thank you so much for the question. And the answer would be probably that if you have somebody specifically with that specific phenotype of seasonal asthma, those patients who have asthma during certain seasons, some of them they have that during either spring or winter, where as well you might have a lot of viruses really around that time, and the patient actually by themselves learn to start treatment even before they start having symptoms. So they say that this is very, very great idea if you know that you have a patient with seasonal asthma to start treatment prophylactically, if you would like to use the term, although it wouldn't be really prophylactic. Those patients, they do have active inflammation in the lung all the time. And the big question will be, should we ever stop asthma treatment? So that will be left probably to a different meeting. Thank you.
Thank you, Dr. Majdi. I'm going to take a couple of more questions, and then I'm going to ask the audience to shift to the networking launch for further discussion with the faculty. The next question is, how do we know if patient is overusing SABA, and what is the danger of SABA overuse? I'm going to address this question to Dr. Mahmoud. Dr. Mahmoud, you still with us?
Yes, Dr. Fatma, just unmuted. Yes, it's a very good question, and I was hoping to hear it. Yes, the SABA overuse is actually very evident of using any bronchodilator. There are two main symptoms. You feel the tremor and the tachycardia. These are the meaning that I'm taking a lot or an increased dose of SABA. The use of SABA for a long period of time downregulates the receptors. When it downregulates the use of the receptors, the beta receptors, that will mean that the use of future SABA will not be enough. The dose that I used to take will not be enough to control the symptoms or to make the bronchodilation that I need. So I need more dosage. That will be toxic. It will be not toxic, but it has this bad symptoms of tremors, tachycardia, and even feeling of more distress. So the use of ICS in general, whatever the type of ICS, downregulates this thing, and it makes the receptor sharper, and it's more good to take the LABA or the SABA and to use it for the bronchodilation. The most important thing in the SABA thing is that it the inflammation is masked, so the patient feels that he's good, and the inflammation is so bad. So when he takes a viral infection in any kind of exacerbation or trigger for the asthma, so it will be very severe, maybe fatal sometimes. So there are the patient that will know that he has an overuse of beta-2 or SABA overuse is the tremors and tachycardia, and it's very evident for all patients. Thank you.
Thank you so much, Dr. Mahmoud. For the sake of the time, I need to close this session. I would like to thank... Okay, Dr. Please, Dr. Ashraf, please, go ahead.
Since Dr. Mahmoud mentioned a point that I think is relevant, and this is a comment on Dr. Mahmoud and Dr. George. Dr. Mahmoud spoke, he mentioned in his talk that when somebody uses a SABA, it seems that the controller that goes with it is always jeopardized, and patients tend to overuse the SABA. And Dr. George spoke about biologics, I think it was Dr. George, and my question is, we start to notice that even in severe asthma, when patients are on biologics, they start also to skip the other controllers because they feel that this shot every 2 weeks or every month or every 2 months is good enough to keep us going without any other controller. So very true. This fast response to any medication or any comfort for a patient or relief, fast relief, makes us unconsciously downgrade any other daily treatment.
Human nature.
Yeah, so I think
if I may, Doctor. May I, Doctor?
Very true. Very true. And face this on daily basis. They don't want to have many medication. It's enough. I think the injection is the magic to solve all the problem. I'm so sorry, my dear speakers.
Just 30 seconds. No, 30 seconds.
I'm so sorry because
Doctor,
I need to shift.
I swear 30 seconds. You know why? because I think the common grounds of all the speakers, and it's so great to be with such good company, is that the relationship between the physician and the patient, to have an individualized plan, to reiterate the importance of the inflammation at the basis of the problem, and to make it a partnership that is continuous, is a key component in achieving asthma control. All the rest is, I think, something that we can adjust, be it the biologics. But I think it is also important, as Dr. Mahmoud mentioned, we have to make sure patients, and I think Gina was partly responsible, we have to make sure physicians and patients understand that short-acting beta agonists alone should no longer ever be used in the treatment of asthma as a modality of control, because this can have danger embedded. All the rest, I think, is negotiable. So good communication, individualized action plans, and then a plan that fits the phenotype of the patient.
I would love you to continue the discussion and the networking launch. People will be very happy to hear this continued discussion, but I have to leave you. I would like to thank each one of you for your valuable contribution, and I'm very pleased to see each one of you. Thank you so much. Please continue your discussion on the networking launch. Thank you so much. Our audience, please stay connected. Just give me a couple of seconds just to shift to the other room. Thank you so much. Good afternoon, and welcome our audience to the second session in the Organon Virtual Congress 2022. Our session is about case presentation on asthma management in children, Protect Your Child's Lung. And I have two great speakers with me. The first is Dr. Ahmed Al-Bladi, well-known figure in the among pediatricians. He's the president of Egyptian Society of Upgrading Pediatric Medical Practice. I'm so pleased to see you today, Dr. Ahmed.
Thank you.
Our next speaker is Dr. Hala Fagali, consultant pediatrician. Most welcome, Dr. from Notre Dame de Sources. De Secours. Okay. My French is getting bad. She's a member of Aspire and secretary of Lebanese Club of Pediatric Pulmonology. She has many publications, latest in 2020 on aeroallergen sensitization in Lebanese asthmatic children, a cohort national study. We'll start with Dr. Ahmed Al-Bladi on a case presentation of asthma management. Please, Ahmed, the floor is yours. Dr. Ahmed, sorry.
Thank you, Dr. Hala. Dr. Fatma, thank you very much for the introduction. Can you see my
Yes.
my slides?
Yes, Dr.
Yes.
And we can hear you very well.
Okay. It's as Dr. Fatma said, thank you for the lovely introduction, and it's a case study, real life case study, and I'm questioning, are we as a healthcare providers or professionals doing good all the time? The case is about a girl, 8 years old, Mona, and this is, by the way, a real life case that presented to the ER at 1:50, almost 2 a.m. in the morning with severe respiratory distress. When the present history taken from the parents, they said that she started 2 to 3 days ago with runny nose, some fever, not high fever, mild cough. They gave her on day 1 some paracetamol, cetirizine, and non-specific cough medicine. On day 2, the fever dropped, but the cough became more intense, noisy breathing, abdominal pain, and on day 2, Mona started her salbutamol inhaler. Mona is known to be asthmatic, so she has the salbutamol at home. On day 3, Mona deteriorated with more breathing difficulty, more abdominal pain, seemed serious, bad temper. The parents became extremely worried, so they came on day 3 at 2 a.m. in the morning. That's Mona in the ER, in the emergency room. She had been in grade 3 respiratory distress, agitated, drowsy, speaking in words, leaning forwards. She was pale. Her pulse oximeter was 87 at room temperature. Respiratory rate was 42 per minute. Heart rate 132. Unfortunately, on examination, markedly diminished their entry with almost silent chest, almost minimal wheezing and no crepitation. Mona was asked, not Mona, in fact, Mona was at that time in a horrible situation. The parents were asked, they know that Mona is asthmatic since the age of 1 year. She always experienced bad winters, according to them. Many unscheduled visits, school absences, more medications, even hospitalization. And in the last month, before her presentation to us, she had frequent wake-ups at night and some activity limitation at school. And here you can see the medications when we talk about salbutamol at 6 a.m. at home on day 2. She started 2 puffs given every 3 to 4 hours. Of course, no improvement and deterioration. So she started at 6 p.m., 2 puffs every 2 hours. She received oral phenadone. The phenadone is the most popular combination in Egypt. It's a steroid, dexamethasone, plus chlorpheniramine maleate in a very modest dose of dexamethasone. She was prescribed 10 ml to be given 3 times a day. The question is, what would be diagnosis, and that's not difficult. I'm sure everybody says that this is an acute asthma exacerbation. By definition, it's acute deterioration in symptom control sufficient to cause distress or risk of death that needed unscheduled visit to the healthcare provider and or require treatment with systemic steroids. What would be the severity of this exacerbation? I'm not talking about the severity of asthma, I'm talking about the exacerbation. And that's very important to know the severity. We have mild, moderate, we have severe, we have also life-threatening. And you can see all the red, that's MONA. That's MONA. So definitely MONA in a severe and life-threatening asthma. And this is, by the way, the hunched forwards position. We say always, if you see it, that's not a good sign. In fact, in the West, they ask the parents to call 911 if the child is hunched forward. And the quiet, silent chest, again, is a very bad sign. We prefer to hear the wheezing chest rather than the quiet, silent chest in an asthmatic exacerbation. Some points were not asked about, of course, because the doctor was very busy with management. The home environment, and unfortunately, the father smokes at home. So MONA is a passive smoker, second and third hand smoke, no pets at home. The past medication history, in fact, MONA have been prescribed SABA to be used as necessary. She was also prescribed ICS, Tigasone, propionate, 50 micrograms to be used, one puff twice a day. MONA, you take it directly from the mouth without spacers, which raises a big question mark. A jet nebulizer is available, but out of order. That sounds stupid. The SABA, MONA, uses 1 canister of Ventolin a month, which almost means 7 puffs a day on the average. And the parents claim that the fluticasone canister is sufficient for 3 months, which is impossible because it contains 120 puffs, so that would be 30 days if she is taking 60 days if she is taking 2 puffs a day. So the management or the medication, what do you think, good or bad? Let us agree at the beginning that asthma management is not a prescription, it's a plan. So you can give a good prescription with a reliever and controller, but you have a disaster plan, and unguided asthmatics, unfortunately, will sink down. The asthma management, as I said, is not a prescription. We need to be sure of the diagnosis, then the medications with the 3 categories, the relievers, the controllers, the add-on therapy. We need to deal with modifiable risk factors like smoking. We need to treat comorbidities. If she had concomitant allergic rhinitis, we need continuous monitoring and management of exacerbation, definitely a written asthma action plan. So it's not simply a prescription. And here are common problem sites. We have problems with compliance to medications, with the technique of inhalation, with the availability of nebulizers, with the follow-up and the home environment and the asthma action plan. So the summary so far, we have an 8-year-old girl who is known to be asthmatic, who presented with severe life-threatening asthma exacerbation with a very bad history related to her asthma control, poor adherence to medication with a father who smokes at home. Now I'll take you to the management and what happened at the exacerbations and the long-term management, and there was no asthma action plan. Usually when we talk about asthma exacerbations, we talk about 4 points at least. Number 1, definitely the salbutamol. Number 2, the oral prednisolone or oral steroids if needed, and they are needed in severe exacerbations. Then the oxygen, of course, if it's available at home, usually not so in the primary care facilities. And number 4, we may use ipratropium or nebulized magnesium sulfate, depends on many factors. So MONA is here in the above 6 years old. The doses of nebulization that should have been used, because MONA is severe life-threatening asthma exacerbation. In fact, she should have received 10 puffs of salbutamol and can be repeated every 20 minutes for 1 hour, then to reassess the situation. If it was mild, she would have received 4 puffs, and the nebulizer dose at this age of Mona is 5 milligrams. If you go to the oral prednisolone, you will find that the dose is 1 to 2 milligrams per kilo per day of the prednisolone, with a maximum of 40 milligrams for kids who are above 6 years old, like Mona. Of course, we had no oxygen at home, so received the oxygen on arriving to the hospital in the ER, and she didn't receive ipratropium or nebulized magnesium sulfate. So far, regarding the medications before arrival, there is a disaster in the SABA. They give 2 puffs every 3 to 4 hours. That you are killing Mona. When there is an exacerbation, there is the puffs should be given every 20 minutes. And Mona used to have it directly in the mouth. I'm not sure whether she can do this or not, particularly when she is distressed. And when you look to the oral steroids, you will find the ugly face of the steroids that have been used. That's the recommendation for systemic steroids, that we need to use prednisolone, 1 to 2 milligrams per kilo per day. A 3-5 to 5 days course is usually sufficient for Mona, and single dose, morning dose, and we do not need to taper. What about dexamethasone? Yes, it is mentioned, although there are few studies, but the dose of oral dexamethasone should be 0.6 milligram per kilo once a day for 1 or 2 days. Just 0.6 milligram per kilo, and should not be continued beyond 2 days, and that's the recommendation of the GINA. Look what steroids that have been given to Mona. Mona received 3 milligrams per day, only 3 milligrams of dexamethasone, while according to her body weight, she needed 14.4 milligrams. So she almost received nothing of the steroids, although her asthma exacerbation was severe and life-threatening. This is definitely a bad management. So summary so far, the doses of SABA were low. The dose of systemic steroid, the dexamethasone, was low, almost nil. Working nebulizer not there. The parents have no action plan. It's not surprising that Mona deteriorated at home. Now let's go to the long-term asthma management. Do you think that Mona's asthma was controlled, symptom controlled? The answer is no. Symptom control, we need to assess by 4 questions in the last 4 weeks before she presents to us. We ask about the daytime symptoms, any night wakening or coughing, relief needed more than twice a week, any activity limitations, and Mona lies in the red zone. The questions were all answered by yes. Daytime symptoms, yes. Night wakening, coughing, yes. All of the 4 questions were answered by yes. So Mona is definitely have uncontrolled asthma. And the categories of asthma medications definitely contain controllers and probably add-on medications. I will not go into the details of this because of the sake of the time, but we all know that there are steps in the management of asthma. Those above the age of 6 years, we have 5 steps, and the medications in the yellow boxes are the preferred controller choice, while in the blue boxes are other alternative options, but the preferred is in the yellow. And you can see, starting from the mild cases from step 1, low dose ICS taken whenever SABA is taken, in the blue box, daily low doses of ICS. Step 2, the preferred option would be daily low doses of ICS. Step 3, and the more you go to the right side, and the more that means, the more you need medications, and we will see now how the medications, how you start with the patient like Mona who coming. Do I start from step 1 or from step 5 or whatever? We will see, but you can see the so-called MART, which is the maintenance and reliever therapy. It starts to appear from step 3, where one of the options would be a very low dose ICS with formoterol, that's called MART, and the very low dose, this means budesonide formoterol 100 to 6 micrograms. And in step 4 also you have the MART, and you have medium dose ICS and LABA. And then in step 5, that's the specialist who will handle. Which step to start with? Each one have the indication. When I look, I think I will start with Mona with step 3, because symptoms most days, or waking with asthma, and more than once a week, and that's the situation of Mona. To start with step 4, I need to do the lung functions, which we didn't do. And if there is low lung functions, I would start with step 4, but I decided to start with step 3. Just a reminder, in children under 5, we have 4 treatment steps only. We do not have 5 treatment steps. What about Montelukast? There is a position?
Ahmed, to interrupt you, if you can just summarize, because Dr. Hala is waiting for her turn. I'm so sorry.
I will finish, I think, in 2 minutes and leave you 2 of the 15 minutes. I will leave you 2. You can add it to Dr. Hala. So the positioning of Montelukast, which is a leukotriene receptor antagonist, as you can see, it's an option as a monotherapy in step 2, and it's an add-on therapy in steps 3 and 4. Some theoretical advantages about the oral intake, the once daily, the steroid phobia, the inhaler phobia, and inhaler difficulties. But please remember that Montelukast will not be used for Mona as a primary. In fact, it can be an add-on, but definitely she needs inhaled corticosteroid. So at home, Mona was prescribed 2 medications in wrong doses, definitely wrong doses. She used to take the inhalers without a spacer, which is another mistake. There was no jet nebulizer at home. Mona was not adherent to the medication. Mona asthma was not controlled, and the exacerbations was clearly predictable, and no written asthma action plan. The father either stupid or misinformed, because he smoked at home, and the parents had no written asthma action plan. Unless we improve our incompetence, we will kill Mona, and we will claim that asthma killed Mona, which is not the case. Thank you very much.
Wow. Thank you so much, Dr. Ahmed. It's always an enjoyment to watch your slides.
Thank you. Thank you.
And I never thought asthma is a horror disease, because I saw your slide and I got scared, but we shouldn't describe it as a horror disease to have it. Actually, if you get asthma control, then they are doing very, very well. Thank you so much, Dr. Ahmed. I can see that people are posting their question on the chat. I'm sorry, I'm not going to be able to take any question. I would encourage you to join the networking launch to discuss all the questions with Dr. Ahmed will be there, and also Dr. Hala. Now, Dr. Hala, your next case presentation, please. The floor is yours.
Hi, good morning. You already know me because of the nice introduction done by Organon. And I will begin with my case presentation, and I hope that the 15 minutes will be enough. So I will begin rapidly with my patient who has 23 months old, and he has like recurrent wheeze, frequent recurrent wheeze, atopic dermatitis, as now he is presenting in the ER for severe dyspnea, worsening than since the last night, with oral salbutamol. I don't know if in your countries it's still available, but in mine there is, against our will, the pediatric pulmonologist, there is a lot of general pediatrician giving oral salbutamol. So this baby, on physical exam, he has a respiratory rate of 45 per minute, a heart rate 140 per minute, an oxygen saturation on the lower accepted is 94 on room air, and he is using his accessory muscles and presenting a intercostal retraction. So this baby was managed in the ER, and after the management, the big question of the parents is my baby will be asthmatic later on, and our challenge is to tell parents this, or and if we must give a preventive treatment, a long-term treatment, which is really hardly acceptable by the parents, and it is our challenge every day in the clinic. So to decide what do we need to know else about the family history. He has two brothers. The two are asthmatic. The first one, 6 years, he has asthma and atopic dermatitis. He's doing well with inhaled steroids. The second one, he has asthma, allergic rhinitis, and he's doing well with Montelukast. And he has a father who has allergic rhinitis, and he is on immunotherapy. So about the child, we did a skin prick test, which came negative, but he has total IgE high for his age, and it is largely explained by his allergic dermatitis. So what we decide to tell the parents, he will be asthmatic, and how to take the decision if we give preventive treatment later on. I will not be discussing because of the short of the time. So we go, Gina give us hints about classification and treatment depending on classification. The classification of severity of asthma, the classic classification, doesn't apply to the children before 5 years old. It's very difficult to decide if the children has nocturnal symptoms or how many puffs he's taking of beta-2 agonist, and we cannot do really FEV1 or PEF for children less than 5 years old. So to simplify things, Gina put another classification for this kind of children. So for step 1, we have infrequent wheezing. It means less than 3 times a year. For step 2, it is asthma or asthma-like symptoms more than 3 times a year. For step 3, it is real asthma. It's not controlled on inhaled steroids or other medication. And on step 4, it is more severe. And it's a specification for children. If you want to know if it is a big challenge for the pediatrician to decide if it's a real asthma or no. We have a lot of other diagnoses who give asthma-like symptoms, like cystic fibrosis, which is frequent in my country. I don't know about yours. It is reflux. It is maybe immunodeficiency. It is a lot and many, many other diagnoses that we have to rule out. So the other kind of classification which can lead us to, or help us to tell the parents if their infant or child will be later on asthmatic child or not. It is the classification done by Martinez, the phenotype, upon a long open study over maybe 30 years. And after this long study, he can divide the asthma population for children in 3 phenotypes. The first one is transient early wheezers, and those are patients who have really a history of prematurity, parental smoking during pregnancy or not, and it means they have narrower airways and small airways, and those children respond not completely respond to SABA or inhaled steroids, and they tend to remit after the age of 2 to 3 years, maybe 6 years after having the growing up of their airways. After the second group is the non-atopic wheezers. They are children who wheeze mainly with viral infection, and we call them the viral-induced wheeze, and they don't have really a lot of allergy or eczema or family history, and they tend to wheeze till the age of 6 and maximum till the age of 10 or 11. And the other group, who are the really asthmatic patient, they begin after 2 years old, mainly after 5 years, they are allergic, and they wheeze apart from respiratory tract infection or viral wheeze. So if we can see this on a chart, the transient wheezer tend to remit after age of 6. The really atopic, persistent atopic wheeze who become really asthmatic later on, and the other group, late onset non-allergic wheezers, they remit till the age of 11 or maybe puberty. So what we have in our hands to decide or tell the parent how it will be their child after. It is Rodriguez who helped us upon the same study, the Tucson study. After a really 30 years of open study, they choose risk factor, or they find there is risk factor to tell the parents if their child will be later on asthmatic or not. So they choose major criteria and minor criteria, and the child must have or one major criteria or two minor criteria to have the risk, or we call it a asthma predictive index positive. So he has the risk to be asthmatic later on. Like major criteria, we have the parent with asthma, or the child himself has atopic dermatitis. With minor criteria, we have allergic rhinitis, wheezing apart from cold, and high level of eosinophilia. So how it can help us? We found that children who wheeze a lot with the positive index, he has 10 times more the risk to have asthma between 6 to 13 years. And a child who even doesn't wheeze a lot, maybe 1 or 2 times of wheezing, but he has a positive index, and those children has 5.5 times more likely to the risk to have asthma later on. And even if a child has wheezing a lot, but he has a negative index, he has the chance, more than 95%, the chance to not being asthmatic later on. This API, or asthmatic predictive index, asthma predictive index was updated in 2008, and we add more major criteria like allergen sensitization, for indoor allergen before 3 years, and for any allergen before 1 year. The family history was extended to parent with atopy and not just with asthma. Atopic dermatitis exists before onset of wheezing after age of 2, and mainly after the big rhinovirus study, we found that a RSV bronchiolitis before the age of 1 year requiring hospitalization. It means it was so severe. It is really a major factor to develop asthma later on. So back to our cases. Rami, he has eczema, he has a parent with atopy, and he wheezes a lot, so he has an API, asthma index, so positive, and he has a elevated risk to be asthmatic later on. And depending on Gina, because he responds very well to our treatment or management in the ER, he is a mild persistent asthmatic. So what are my treatment options? Upon Gina and our phenotype, my child is asthmatic and needs long-term treatment. How to decide? We have many options. We have Montelukast, it means the leukotriene receptor antagonist, inhaled steroids. We have a combination between steroids and leukotriene antagonist receptor, and we have other option of inhaled steroids and LABA. So how to decide? So Gina put the guidelines, and I will not explain all because of my time. So I will tell about what it was new in the Gina guidelines or treatment for children. Since 2019, Gina changed and put the asthma treatment or management of the crisis, and they add the steroids. And later on 2020, they add the steroids for asthma management, inhaled steroids, for the group between 6 to 11. And after this, in 2022, we talk about intermittent short course of ICS at onset of viral illness with add-on the short-acting beta agonist for the children, and it may give preventive effect. So my child was step 2, and
if you can summarize in 2 minutes, please. Sorry, Dr. Ahal.
I have just 2 minutes. I will try. So my child, it's in step 2, and so my treatment option, the most likely are inhaled steroids or leukotriene receptor antagonist. So I will not talk about the details, and I will give another point of view. It is the Practal. So the Practal is an association between 44 pediatric pulmonologists between Europe and US. And this Practal, they put guidelines depending on the phenotype of asthma. So I will go rapidly. What are the indications for leukotriene receptor antagonist? It is an alternative first-line treatment for persistent asthma. It is useful as an add-on therapy when we have moderate to severe asthma, and it is suggested really for viral-induced wheeze. Why? Because during virus-induced wheeze, we have a elevation of level of leukotriene in the urine of the patient, and it is an indication or alternative treatment for exercise-induced wheeze. For inhaled steroids, it is a first-line treatment for persistent asthma, as we know, since 4 years. So it must be done when we have uncontrolled asthma, when we have atopy and lung impairment, if you want, of the function lung impairment, we must put steroids. And if controlled with low dose of steroids, we must go for add-on therapy. So till now, my treatment option are for the first line for mild persistent asthma, it's or montelukast or inhaled steroids low dose. I will not go for association because it is not step 3 or 4. And just to tell you that LABA are not indicated anymore for children less than 6 years old. So it is not done when we put the long-term treatment. We must go and follow on our patient, and that's how we do better. And like Dr. Belidi said, we have chart for controlled asthma. It is the day symptoms, night symptoms, the dyspnea and limitation, effort dyspnea or limitation or activities, the need for reliever, and the lung function, which is barely enough, not done in children before 5 years old. So we have in children a chart, a question. The parents will come to the clinic for visits after we give long-term therapy, and excuse me, depending on the answers of the parents, we have score to put, and the questions are about activity limitation, about dyspnea with effort, about the use of beta-2 agonist, and about mainly the overall impression of the parents after putting our treatment. And if we have an idea, a score less than 20, it means our asthma is not controlled, and a score between 20 to 25, we have a controlled asthma, and we can down or manage a child after all. So thank you. I hope I didn't go with the...
You both did very great. I thank you for the amazing presentation. Very beautiful slide, very clear, very straightforward. I would like to apologize to our audience for not being able to take any question, but the speakers will be available on the networking launch, so you can just direct the question and continue the discussion. I have to leave you to the next session. I'm so sorry. I would like to thank you both. Dr. Ahmed, very pleased to see you again. الله يطول في عمرك ويخليك. شكرا جزيلا. الله يسلمك. دكتورة حالة شكرا جزيلا. سعيدة التقيت فيك. إن شاء الله نلتقي مرة ثانية. شكرا جزيلا. Thank you both of you. with the audience on the networking launch. They have a lot of questions to ask you.
Thank you, Dr. Fatma. Thank you.
مع
Thank you.
السلامة.
مع السلامة. مع السلامة.
Good afternoon and welcome to the third session of the Organon Virtual Congress 2022. I would like to welcome our speakers, our esteemed speaker and our audience to this session. This session will be about case workshop on persistent allergic rhinitis and sinusitis in pediatric patients. It's given me a great pleasure to introduce our speaker, and I would like to start with Dr. Ahmed Al-Khabbaz. He is consultant and head of allergy, asthma, and clinical immunology unit in the pediatric department of Mubarak Hospital with over 10 years experience. And the next speaker is Dr. Rula Suleiman, Ahla wa sahla, a PhD certified from American University in Beirut and a lecturer and Lebanese University with over 20 years of experience in pediatric disease, chronic and infectious disease, as well as picky eating disorders. Please, the floor is yours, and I would like to ask our audience to share their questions and comments on the chat, so I will be able to share them with our faculty. Thank you, Dr. Ahmed. The floor is yours. Please go ahead.
Assalamu alaikum. Thank you, Dr. Fatma. Thank you, Organon. Pleasure to be among my friends and colleagues, and Jum'ah Mubarak to everyone. It's my pleasure to talk to you today about allergic rhinitis. There's a bit maybe of some overlap between the lectures, but that's all with a special benefit, inshallah, for the audience. I'm going to talk as introduction about allergic rhinitis definition and symptoms briefly, then talk about the pathophysiology briefly as well, the diagnosis very briefly, and the management. And we'll start with a case. And you can see in this slide a very common feature of allergic rhinitis, which is the allergic shiners of the eyes, and that's a very common presentation. So the case starts with the following. We have a 7-year-old boy who is presenting with cough, mostly at night, snoring at night regularly, awaking from sleep sometimes over the last 3 months. His parents say that the school teachers report that the child is not doing very well at school with his school performance, and they complain of headaches sometimes, and on examination they have found nasal congestion with the doctors, and the chest was clear. He has used intranasal steroids for the past month and has improved somewhat, although not much. He still had the snoring and nasal congestion, and he had 3 ear infections in the past year, prescribing antibiotics through the pediatrician as well during that time. So this is a poor question, just just briefly, what is the most probable diagnosis? Chronic rhinosinusitis, adenodal hypertrophy, persistent allergic rhinitis, number 1 and 2, or number 1 and 3. It's a difficult to answer question, obviously, and we'll not wait for the poll. I just want to explain that at this time we have a 3 months history, so the chance of this being adenodal hypertrophy is down the list, but chronic rhinosinusitis is a high probability. I cannot rule out at this stage rhinitis or persistent rhinitis as a cause of the problem. So by definition of rhinitis, you have to differentiate between rhinitis and allergic rhinitis. And rhinitis, by definition, is an inflammation of the lining of the nasal mucosa as well as the surrounding area, persistent with showing anterior and posterior rhinorrhea, sneezing, blocked nose sometimes, and itching of the nose. That in itself doesn't tell you if that's allergic rhinitis, it just tells you that it is a rhinitis. So often can be a okay. With allergic rhinitis, you have to identify an allergen. And before identifying an allergen, an environmental allergen, you cannot say this is an allergic rhinitis. But allergic rhinitis is either seasonal or perennial, and seasonal occurs in different times of the year, usually between 2 and 3 months, and perennial is persistent throughout the whole year. So we know that rhinitis acute symptoms are quite common, sneezing and congestion, but the chronic symptoms are often seen or underappreciated. And those chronic symptoms can include chronic cough and congestion, include as well poor asthma control as a complication, include frequent sore throat and hoarse voice, as well as headache and sinus pressure, recurrent otitis media and hearing effect sometimes, disturbed sleep and snoring, poor memory, concentration, and work and school performance. And that's an effect actually of the poor quality of sleep rather than the rhinitis itself. And unfortunately, social stigma, because that could be showing only with very bad mouth smell. So the question here, what is rhinitis and what is allergic rhinitis? And allergic rhinitis depends on atopic rhinitis, and that's by definition not only an IgE-mediated disease, but as well an IgE-mediated disease with a genetic predisposition. Hence, we have an association with other IgE-mediated disease which have genetic predisposition. For example, patients who have asthma have eczema and rhinitis as part of the atopic spectrum, which is IgE disease with genetic association. Now, although food allergy, drug allergy, and insect allergy are IgE-mediated, they're not part of this atopic spectrum because they don't have a clear genetic association with the other pathologies in the atopic spectrum. There's a familiar basis for that, but you can see from the slide that even patients who don't have any family history of any rhinitis or atopic disease can develop in around 14% of the cases some allergic rhinitis or atopic syndrome. Although if you have a family history, then you have a higher risk of development of allergic rhinitis. So just because you have family history does not mean you always get allergic rhinitis. And even if you don't, there's a small chance of about 15% or so that you can develop some atopic disease in the child. The atopic march is the relevance component of the allergic rhinitis with other atopic disease. So you can see that those children with a family history, they develop starting with some food allergies and eczema, and then they develop slowly into more asthma symptoms, and at the end, they would develop a lot of the allergic rhinitis spectrum disease. So they go through what we say about the atopic march, which means IgE disease to IgE disease and association. So basically, a child who has allergic rhinitis has probably before experienced some form of other atopic disease, whether that's asthma, eczema, or even sometimes food allergy as well, although not specifically an atopic syndrome. The pathophysiology is a bit complex, but essentially, whether it's an allergen, a microbe, a pollutant, an oxidant, or an irritant, they impact the skin of the nasal mucosa and the skin of other areas. They result in native T cell activation, Th2 activation, and production of I through the B cells, and that results in mast cell degranulation, producing all the inflammatory mediators, the histamines, the leukotrienes, the prostaglandin D2, and other cytokines. And that results in inflammation. So basically the runny nose, the congestion, the itch, and so on. And you can have a late response as well, and that basically presents chronic congestion. So the late allergic rhinitis patients will not experience a lot of the sneezing, but can experience a lot of congestion and nasal blockage. Why do we get allergic rhinitis? We don't really know, but we know that allergic rhinitis is a Th2 mediated response. And a lot of associations that result in Th2 responses result in more atopic disease. Many of them are related to the modern society. The use of antibiotics, prematurity, early or late introduction of foods, being a single child. Boys, unfortunately, I don't know why, maybe they deserve it. But anyways, single children who don't have involvement with a lot of normal environment and lots of artificial environment are at higher risk of development of allergic rhinitis. In fact, rhinitis and other atopic disease are disease of the rich countries. So the richer the country is, the more prevalent and associated rhinitis and other atopic disease is. Pollution plays a part, so they play a part into inflammation as well, although pollution is not allergic, but it complicates the picture. And we have a lot of pollution in our region as well because of the industries close to the residential areas. And that's associated with a lot of inflammation, whether that's nasal, eye, lungs, skin, or other. The differential diagnosis, Dr. Suleimani will talk later about that in more detail. I just want to show that there are different causes of that, whether they are structural causes, functional, or hormonal. So just because you have a rhinitis, which means inflammation, it doesn't have to be an allergic rhinitis. Specifically, even in the younger age, under 1 year of age, the incidence of allergic rhinitis in under 1 year of age is almost zero. You do not develop an IgE for allergic rhinitis under 1 year of age, although you have a lot of the other rhinitis causes, which includes pollution with smoke, bukhur, cigarettes, and other structural abnormalities. So it's important to note allergic rhinitis is actually uncommon and very rare in the young children under 1 or under 2 years of age, although they have a lot of rhinitis symptoms. With classification as well, you have a lot of viral, allergic, drug-induced, hormonal-induced, other causes, but even idiopathic. But most importantly, a lot of those cases can be mixed, especially the older children population and the adults as well. Examination findings, typically you find the nasal mucosa is ternates are swollen, boogie, there's nasal mucosal bridging, there's the allergic shiners and Deney Morgan lines. As well, you can find the allergic salute, basically as a result of excessive rubbing of the nose. That's called allergic salute, and it gets a mark around the nose indicating that. The investigation for specifically allergic rhinitis involves the IgE testing, and that can be done by skin prick testing or by serum testing for indoor or outdoor allergens. And basically, it should be done only above 2 years of age because the chance of allergic rhinitis is much less under that age in specific. And indoors, the pets, the mold, the dust mites are the major causes, while outdoors you have a lot of pollen, mold as well, and in special cases, exposure to farm animals, like horses, for example, cattle and feather as well. You can do skin testing or blood testing, and the skin prick testing is immediate result, and it is more sensitive, meaning it indicates the results of allergic symptoms more accurately, while the blood test is more specific, although you get a lot of false positives on the blood test as well. If it's a negative test, then that's a good test. Either it's skin test or blood test. If it's negative, then it has more than 95% confidence interval that it will be a negative test. And a very important association because of atopic disease, if you have rhinitis, you have a 3-fold increase of development of asthma. And if you have asthma with rhinitis, without treating rhinitis, the asthma will be poorly controlled. So it's important to do the concept of united airways, meaning treat the nose as well as you treat the chest to make sure that the chest is well controlled. And this one particular study is repeated by multiple studies that show the same evidence. If you have no allergic rhinitis, your development of asthma is 1/3 of the chance of development of asthma if you have allergic rhinitis at baseline. With regard to the guidelines, just to show the WHO and ARIA functional guidelines, basically, if you have intermittent rhinitis, it means it's only affecting you less than 4 days a week and more, or less, than 4 weeks per year. Otherwise, you have a problem with your rhinitis, and at this stage, intranasal steroid should be prescribed. So unless it's an intermittent rhinitis, then you should have intranasal steroid prescribed to you. And that involves any impact on life, whether you have abnormal sleep, abnormal day activities, or effect on school, or any troublesome symptoms. The treatment cornerstone of treatment is intranasal steroids and the treatment of choice. It's more effective for nasal congestion and for dust mite allergy as well. And if you fail to respond, you often have either poor compliance or ineffective use, although some of those patients would require allergy-specific immunotherapy. Allergy-specific immunotherapy involves giving a spray or an injection to children above 3 or 5 years of age that has the allergen component. Often that's either a cat or a dust mite or a pollen that's common in the environment. Intranasal steroids are generally considered to be very safe. You can see from this particular slide the bioavailability of the steroids within 12 to 24 hours. You can see the mometasone is only available less than 0.1% after 12 to 24 hours of regular dosing. Fluticasone furoate 0.5. Other steroids tend to be a bit higher. You can get up to budesonide up to 30%, and beclomethasone, triamcinolone up to 40%. Still, that's a very small amount that goes into the circulation, because puffs are usually around 50 micrograms per puff often, or 27 micrograms. But you have to be careful about the impact of added steroids. Basically, those patients have a lot of asthma and they can have topical steroids. So overall, there's a steroid burden on these children, even though the nasal steroids are considered to be extremely, extremely safe.
Sorry, Ahmed, Dr. Ahmed, for the interruption. You have just 1.5 minutes, please.
That's all I need. Thank you very much.
Thank you.
Okay, so just a couple of slides about Kuwait experience. We know multiple studies have been done to show the major pollen in Kuwait environment, and they're actually quite common in the Emirates and other Gulf states as well. And we found that the majority have a peak allergic season in October, September-October time, and a smaller peak in April-May time. And the cause of those allergic seasons are two major pollens, the Chenopodiae, and Amaranthe, and I'll show you the couple of those weeds. Basically in Kuwait, we call them the Arfaj, or the family of the Arfaj, or tumbleweed, which are the most common allergic causes in this season between August, September, and October. And you can see as well that these are some pictures of the Chenopodiae, which are, they grow themselves all over the place without anybody seeding them. If it's an open area, they have them as well, and they're quite common in the environment all over. And you can see here that the other season between March and June is peaking, usually because of the Bermuda grass season. So these are the two most important seasons that you should be careful of. And we have prophylactic medication. Please don't stop your prophylactic medication for asthma or rhinitis during those particular seasons. So in summary, allergic rhinitis is common, although in the young age they are not allergic. They're mostly rhinitis, but not allergic rhinitis. You need to consider your differential and investigation. The intranasal steroids are generally safe, and they are the first choice of treatment for all allergic disease. And there are guidelines to follow up on that. I did not discuss immunotherapy because that needs another session, but basically giving the patient an oral spray with the allergen in small doses for 3 to 5 years can result in the resolution of rhinitis and prevent the development of asthma as well. The Chenopodiae species and Bermuda grass actually are the most common predominant pollen in our region. Thank you very much.
Thank you so much, Dr. Ahmed. Before we start with Dr. Rola and her case, I would like to encourage our audience to post their question and comments on the chat, so I will be able to share them with our esteemed speaker. Dr. Rola, please, you have 13 minutes exactly, so we'll give the audience time to share their question and discuss them. Thank you so much.
Okay. Can you hear me?
Yes, we do. Please go ahead.
Okay, thank you. Thank you for inviting me to this international event, and thank you for COVID that make this event more frequent, since we have from different parts of the world. I think that it's very difficult to present this topic after the presentation of Dr. Ahmed. since he has overview everything almost, I will go like point. I will be short. I am seeing this problem as general pediatricians. And I think that we are the first to face such patient, and referring them to an allergist or ENT is something that we do usually when they are not well treated or we have a problem of diagnosis. So what I will go is just an overview. It's like the interesting and the point that a general pediatrician need to have just in mind to see when he see an allergic rhinitis pediatric patient, and how to refer him, what to treat, what not to give for this patient. So we wish if we did do this as a case presentation, but it was like we were asked to do like a review of literature, and I invite the audience to review these two nice papers. The first one is Euphoria. This is the European Forum of Research and Education in Allergy and Airway Disease with the guidelines of allergic rhinitis, and the other paper is about the allergic rhinitis in general. So allergic rhinitis is the association of two of the four symptoms that everybody knows: sneezing, runny nose, blocked nose, and itchy nose. This is, like Dr. Ahmed said, it's not all the time allergic. It can be allergic or from another reason, infectious, can be infectious or non-infectious, non-allergic, for example, for pregnant women. Allergic rhinitis is an IgE-mediated allergy, so it is a sensitization to inhaled allergen and can affect the quality of life. So this, how it affects the quality of life, we classify the allergic rhinitis in pediatric. If you have a child who is having 1 or 2 days of runny nose and he's going to school, he don't have sleep disturbance, he don't have anything, it will be classified as mild form. But if we go more than this and it starts to affect the quality of life, it will be moderate to severe. It can affect also other organ because of this united anatomic. And we have the sinus and the lung, the ear, who can be affected. Still sharing. So the natural history, like Dr. Ahmed said, we cannot see allergic rhinitis before the age of 1 year or 2 years. Why? Because it needs sensitization. It needs that the allergen go in the body, make the IgE, and there is studies telling that the IgE level is elevated while the child is having any sensitization. So we need at least 2 to 3 years to start to have the allergen. Of course, if I ask you for a seasonal allergic rhinitis, somebody who is experienced allergy at the spring, which one of these causes can be, you will answer, for example, for the spring season, that it is the trees. So the pathophysiology, the most important is to know that there is an IgE-mediated mechanism that lead to degranulation of the mast cell and increase the inflammation. And this inflammation will act more and more as a chronic. So basically the prevalence is different, but we have seen the last 15 years a lot of allergic disease, because it is all the allergic diseases are increasing, especially asthma, atopic dermatitis, and we have a percentage like 40% prevalent in children. 80% will present during the first 20 years of life, then the peak between 20 and 40, and decline later. For the prevalence, there's no prevalence for the race or the sex, but the problem that we have seen in the cohort, a male predisposition in childhood phase, and for the female later on in adolescence. More severe forms are seen in Africa and Latin America. For the cost, of course, it will cost too much because you have this impact on the life. Allergic rhinitis do not kill, but it causes many visits to the pediatrician, to the allergist, because of this discomfort of the patient. The patient described themselves as miserable. So when we classify the allergic rhinitis, it is either according to the symptom itself, so if it is related to the quality life disorder, we can classify it also according to the symptom, how much it will stay, 4 days per week, more than 4 weeks or less, and according to the season, if it is the whole year or seasonal. So the risk factor, like Dr. Ahmed said, there is many risk factors, but I will point some who are really specific to pediatric. We have those who are breastfed, they are more protected than the formula, and we have many studies showing that those who take formula, they have more than 5-fold time to have allergic rhinitis. Those who are delivered by vaginal delivery versus the cesarean because of the microbiome, the genetics plays a role when you have 1 or 2 parents who are allergic, and the smoking, either the smoking of a pregnant woman or the smoking individual, the passive smoking in a house, plus all this change in our life because of the industrialization. So many people, they have seasonal allergy. Which disease you have to worry in our region mainly? I think that everybody knows it is the asthma. And when you have a child in your clinic coming just from the door, you can detect the sign of allergy with his allergic chiner, with the other symptoms that we need to look at, like the eyes, the watery eye, tearing eye, the skin of an atopic dermatitis, and the recurrent infection of the ears. So these signs are in the clinic. We need to check them very well. Don't forget, there is sometimes a very rare event that can happen because of the sensitization to allergen. Some baby, when they take some food, they develop like swallowing difficulty, swelling of the oral mucosa. This is what we call the syndrome of allergy to pollen food. It's related. They have allergy to pollen and they develop allergy to the food. And we can detect such patients and give them really prophylaxis because they can go to anaphylactic shock. For the investigation, we don't have, as pediatrician, a lot of investigation or a gold standard diagnosis, but we do use the IgE specific or general. And we need also to be careful not to do X-ray for nothing, because if you are doing X-ray, it's not to diagnose allergic rhinitis, it's to see other mimic. So the other mimic, it's very important. The most important is the adenoid hypertrophy that can cause and be exaggerated by the allergic rhinitis. We have the other complications that related to general disease, like, for example, nasal polyp, cystic fibrosis, having unilateral discharge. You have to think about foreign body, the anatomy that are congenital anomalies. And we have also from the medication itself, sometimes a long time antidecongestion, they can give rhinitis medicamentosa, and this is because of the medication. So if you have a patient with severe seasonal allergic rhinitis and you cannot avoid the allergen, and the drug treatment with the steroid and antihistamine is not working, what are you going to do? So the answer is the immunotherapy. Rola Sleiman, as a pediatrician, will not treat this patient. I will send him to an allergist. Why? Because my option of treatment are mainly, as pediatrician, the education of the patient for avoidance and some of the pharmacotherapy. Immunotherapy is from the specialists in the field. And for this reason, if we will talk about the avoidance, we have to be sure that if the allergen is indoor or outdoor. And according to the history, we can catch most of the allergens that are playing a role in the allergy of the child. We need to tell to the mother to wash her child every night when she go out and come back, because keeping the dust on the body will increase the reaction of sensitization over time and will increase the severity of allergic rhinitis. We have to have a HEPA filter at home, use the vacuum, use the water for cleaning of the furniture of the house. For the treatment, like we said, we have the antihistamine, but we have to use the newer generation because they are without, between brackets, side effect. And the intranasal antihistamine, they act better on allergic rhinitis. For the correct administration, this is the position that the child needs to have while he's doing his nasal spray. And for the decongestion drug, we need to be very careful because they can have a rebound effect when used more than 1 week. Steroids are very important, and they are the cornerstone of treatment of allergic rhinitis. Approved in pediatric age above 2 years. Anyway, you will not have an allergic rhinitis in a child less than this. and they are not safe 100%. They have there is described some side effect related to the growth mainly, but in a very small percentage. This is why the pediatrician need to follow the growth of the child and need to be careful in immunocompromised patients not to have a fungal superimposed infection. The leukotriene receptor antagonist, we have used this as monotherapy for a long time, but in the new guidelines, we don't have the right to do this. We need to use that in a specific case when we want to control the night symptoms, mainly when we have an asthmatic patient, they act very well with the asthma patient, because you know that if you have an allergic rhinitis untreated, you have twofold more risk of going to emergency room, and you have more than 3 times risk of being admitted for asthma and controlled to the hospital. For the immunotherapy, it can be cutaneous or sublingual. It is done by the specialist. And here is my algorithm, how we will work. So we are here. I am a general pediatrician. I will use basically the antihistamine and nasal corticosteroid. When it doesn't work, when there is failure of treatment, I will send to the subspecialty who will have the right to use other medication as immunotherapy. At the same time, you have to be careful. When you have association with asthma, use anti-leukotriene. When you have ocular sign, treat the ocular sign either by antihistamine or local steroid. And if you have a sudden blockage of the nose, you can use the decongestion for less than 7 days. So basically the combination, the review of literature has shown that antihistamine nasal with steroid nasal is better than oral with steroid nasal, that antihistamine with anti-leukotriene are better than leukotriene alone, and the spray of steroid and the antihistamine are better than steroid alone. These 2 papers from our region, from Saudi Arabia, where I'm working, show very well that there is a prevalence of more than 30% of allergic rhinitis in kids. 1/3 they have school problem and they have sleep disturbance of this population. And we have noticed that those who are basically formula fed, they have more risk for allergic rhinitis, and those who are having obesity also, they have more risk. So this is in short my lecture, and thank you for your attention.
Thank you so much, Dr. Rula, on time, very clear and straightforward. Thank you, both of you, great presentation. I have a couple of questions that I can share it with you, Dr. Rula. Perhaps the first question is, how about antihistamine? I think you mentioned that in your presentation. And allergic rhinitis, what is the role, if there is anything?
So the antihistamine, we said that there is 2 generations. The old generation with the side effect. So we don't want, we can use cetirizine, desloratadine, Lorine as a medication of antihistamine. So they are in the algorithm first line, and we are the one using them. Now, the idea that antihistamine sometimes they don't treat well the night symptoms. They are more effective on the daytime symptom. And at the same time, sometimes we need to add on, not alone. Okay?
Very clear. There is a special request from Dr. Ahmed to share his pathophysiology slide. If you would like to do that, or share it with the organizer so they can forward it to the person who asked the question. I think we can close here, so the next session would start. I thank both of you speakers for the great presentation and your time and your effort. Thank you so much. Thank you, the audience, for keeping in touch with us. Stay on your Friday afternoon listening to us, and I hope you had benefit of this presentation. Thank you so much, and Jum'ah Mubarak, inshallah.
Thank you, Dr. Fatma, for your
Thank you, Dr. فرصة سعيدة. دكتور أحمد، شكرا، فرصة سعيدة. أهلا وسهلا.
Okay, so hello everyone and welcome to OSCAR version 2.0. My name is Michael Sadiq. I'm currently a medical advisor for Organon based in Cairo, Egypt. And I would like to thank you all for your participation and your interest in this great session. We have till now live more than 1,500 attendees, so this is a huge number, showing the interest for all of you in dyslipidemia management. So today we have a very rich agenda for dyslipidemia with lots of interesting topics. And we will start by a panel discussion. The panel discussion is titled Dyslipidemia Management Between the Latest Guidelines and Recent Recommendations and the Need for a Paradigm Shift. And we have an eminent group of experts with us today. So I will introduce our moderator for the panel today, and he will introduce the rest of the speakers. So without further ado, I'd like to welcome Dr. Hani Sabour. Dr. Hani Sabour is a consultant cardiologist and electrophysiologist in Cleveland Clinics, Abu Dhabi. And he's also former internal medicine residency program director at Al Ain Hospital, Al Ain, United Arab Emirates. So Dr. Hani and Dr. Tahir, Dr. Ada, and Dr. Banak, we're very happy to have you with us. Dr. Hani, the floor is yours.
Thank you very much. Really, it's a great pleasure to be here amongst my dear friends and really esteemed colleagues. We have the pleasure of having three really genius cardiologists with us today. So, without much, I'm just going to introduce each one of our speakers and then we'll launch into the discussion. So we have the pleasure, of course, of having Dr. Hassan, who's a consultant intervention cardiologist in Jeddah, Saudi Arabia, a lot of experience in hyperlipidemia management as well. We have Professor Maciej Banaś, who is a consultant cardiologist and lipidologist at the University of Lodz in Poland. He's also the secretary of the European Atherosclerosis Society and the president of the ILEP expert panel. And last but not least, my dear friend, Dr. Adel Khalifa, who is a consultant cardiologist, electrophysiologist at Mohammed bin Khalifa Cardiac Center in Bahrain, again with a vast experience in clinical cardiology as well as EP. So I think we'll kick off this important session, which is clearly about hyperlipidemia, to Dr. Maciej. Can you please share with us the status of the dyslipidemia control based on large epidemiological studies? In particular, I'm referring to the Da Vinci and Santorini studies.
Okay, thank you very much for the nice invitation, and thank you very much for being with you. And if you allow me, I will share a few slides in order to answer this question, because I believe it is critically important. Okay, these are my declaration of interest. We know it very well that, and probably the whole session will be dedicated to this, to understand that we should be as early as possible with the LDL cholesterol achievement and as low as possible for longer, because preferable for the lifetime. Because we know it very well that hypolipidemic therapy is probably the most preventable therapy in the cardiology, because if we are on the LDL cholesterol target for 40 years, we might prevent cardiovascular disease events by even 55%. And this refers not only for the patients with hyperlipidemia, which is secondary hyperlipidemia, but especially for those patients with FH and homozygous FH, because if there is an early diagnosis, if those people are treated suitable, we might have the life expectancy the same in comparison to those without any genetic predisposition. However, this is academics. Let's look at like the situation looks like in the real life data. Please have a look at the very beginning from the reality study from the Spain that was presented during the European Society of Cardiology meeting in Barcelona. These were data of almost 2 million people by 2019 of atherosclerotic cardiovascular disease patients. And as you can see, only 2.9% of those patients were on the target below 55 or 144 millimole per liter. And altogether, about 40% of those patients were the target below 70. So the previous target based on the 2016 European guidelines. If we look at the cardiovascular disease events and deaths and mortality, please have a look at the highest number of deaths were in those patients with cerebrovascular disease and peripheral artery disease. So this is probably the largest unmet need. If we look at this, we may understand this, because you know it very well that in fact patients with peripheral arterial disease mostly in Europe and US are not diagnosed in cardiological departments, and they are transferred to the interventional surgeon. So that's why probably it is a challenge we need to definitely change. If we look at the Da Vinci study, it is 6,000 patients in 18 countries. Please have a look at the overall data. You remember probably that only 1/3 of those patients were on the LDL cholesterol target. And what is the main reason of it? To be very short with this, most of those patients had unsuitable dose of statins because most of those patients were treated with moderate intensity statin therapy. Only 1/4 of those patients were treated with the high intensity statin therapy. And as you can see, there were almost no patients treated with the PCSK9 inhibitors, and only less than 10% were treated with the combination of statin and ezetimibe. If we look at the primary prevention group, the situation was even worse because even 2/3 of those patients are treated with low to moderate statin therapy, and this is probably the largest unmet need because we do not consider patients without established cardiovascular disease as those who should be treated intensively. So that is why we need to change it definitely, because you know it very well that we need not only to prevent the recurrent cardiovascular event, the recurrent next cardiovascular event, but the first cardiovascular event is probably the most important to be delayed or to be prevented. If we look at the secondary prevention patients, with those with established atherosclerotic cardiovascular disease, you can see there is a situation a little bit better because almost 40% of those patients are treated with high intensity statin therapy. But again, 4% were treated with moderate intensity statin therapy, and as you can see, only 9% of those patients with ezetimibe in the combo therapy, and only 1% with PCSK9 inhibitors. So that is why, in the end, if you look at the number of patients being on the target dose in secondary prevention, those that are needed to be as low as possible, please have a look that only 18% of those patients were on the target. And if we look at the region I represent, so Central Eastern European countries, the situation is even worse because those those patients being at the high cardiovascular or extremely high cardiovascular risk, those patients are treated with high intensity statin therapy in about 32%, and only 13% are on the target below 55. Okay, how the situation looks like in the Santorini that was presented during the European Society of Cardiology Congress in Barcelona. This is a kind of continuation of the Da Vinci study. There was only a small increase of patients being on the target below 55 because it was 20.7%. So it was an increase by 2.7%. As you can see, there was a better situation of patients with the combination therapy of statin and ezetimibe, but most of those patients again were treated with monotherapy. And again, the highest impact we should put, or the largest unmet need, was for those with peripheral polyvascular disease patients. So that is why we should focus on those patients definitely, because these are also patients that have high or very high or extremely high cardiovascular risk. Thank you very much.
Okay, thank you very much, Professor Banish. That was really a very important reason why we're having this meeting. It seems that the majority of our patients in primary or secondary prevention fail to achieve LDL when, as you said, the WHO has called this the single most easily attackable form of cardiovascular disease prevention, and it's really kind of a low-hanging fruit, unfortunately. Do you have any specific insights from the studies why this could be? Is it a physician problem? Is it the guidelines changing? Is it patients? What's the problem? Do you have any way we can fix this issue?
Yeah, obviously, but I believe that this is a question that will be raised a little bit better concerning the physical inertia and non-adherence, that I would like to focus a little bit later. But to shortly and briefly answer your questions, obviously these are, first of all, the issue associated with the physicians. Most of our colleagues do not use high-intensity statin therapy, and especially do not use combination therapy with statin and ezetimibe, which is very cheap now and available for everyone, in fact. And in fact, that is why we introduced in 2019 within the International Lipid Expert Panel the approach of the upfront combination therapy with statins and ezetimibe, especially for those high-risk patients and very high-risk patients, because we will, based on this therapy, especially with the polypills, with the fixed-dose combination, we might have 65% reduction of LDL cholesterol, and for most of those patients, we might be on the target. So for even 70%, hypothetically, we might be on the target. So probably it is the first reason. And the second issue is associated with the education of the patients. We need to have convinced patients that they should be treated with lipid lowering therapy, because you know it very well that the fake news concerning the study are probably the largest problem. Thank you.
Thank you very much I know you have some more slides for us. So we'll go now to Dr. Tahir. Could you share with us the prevalence of dyslipidemia in the Middle East, North Africa region, and the control rates among the different groups? Particularly, I think we need to focus on the large proportion of diabetics in the region and the post-ACS patients. I think that would be instructive to see if it's similar to what was Professor Banish's presentation, or is it somewhat more or less? Please go ahead.
Thank you very much. I'm very glad to be with you in this OSCAR meeting to discuss the prevalence in Gulf and the MENA region and to see the gap of management. And as you know that when we talk about cardiovascular disease and mortality in our part of the world, the cardiovascular disease account for 45% of all mortalities. And simply look at Saudi Arabia, you see that 37% of the total deaths in KSA due to cardiovascular disease, more than anything else. And as LDL or hypercholesterolemia is the leading cause for cardiovascular disease, we find as early as 20 years that is hypercholesterolemia, hypertriglyceridemia are prevalent in this part of the world, and also low HDL, where you find a 75% prevalence of low HDL less than 40. When you look at Africa and Middle East, still dyslipidemia is #1 cardiovascular risk factor. And what makes it different from the others is the fact that from the Gulf race, that the presentation of acute myocardial infarction is 10 to 12 years earlier than the Western part. And that's also in Interheart Middle East studies, where you find the age of the first MI in the Gulf region is around 51, and the large proportion of patients are below the age of 40. And there is an associated elevated apolipoprotein B and A B ratio and B1 and A apolipoprotein. Also, we observe that patients that comes to the emergency room with acute coronary syndrome, that 46% they have metabolic syndrome, and there is a great association with heart failure and recurrent ischemia. The same applied on diabetes, the high proportion of diabetic patients among the acute coronary syndrome with increased recurrent ischemia. And when you look at the low HDL, we find in the Gulf race survey that 62% of patients with acute coronary syndrome come with the low HDL, which is the highest reported studies in acute syndrome in the region. And with it, there is a high proportion of mortality, cardiogenic shock, and worse prognosis. Familial hypercholesterolemia is another issue where it is higher in our part of the world because of the highest consanguinity. And when you look at the recent Gulf familial hypercholesterolemia registry, the Gulf FH, is the prevalence of probable and definite familial hypercholesterolemia is 1/232, and this paper was released a couple of years ago. So what is the situation now that you are facing using statin alone? The data has shown that when we summarize what has been mentioned about the gap, that it is from the part of the physician that there is a lack of awareness and lack of adherence to the lipid guidelines by the physician in the Middle East. So there is a wide gap between the guidelines and the current daily practice. And a large proportion of the high-risk patients, they are not attaining the goal. Maximally 60% of them, they attain the goal. And the physician used to write an excess of statin, which is not a high-intensity statin, moderate or low-intensity statin, in situations that demand the reduction of 50% of the LDL at the initial point before reaching the goal. And many of them, they are not aware there is something called non-statin therapy that can be combined with a statin. You should know that when you look at high-risk statin, you have to, high-risk patient, you have to use a high-intensity statin above 50 and not the rest. And you should know that statin has also limitations, that when you double the dose, you are not reducing by 50%, but you are reduced only by 6%. The maximum you can achieve from high-intensity statin is a reduction of 55%. And so you end up in the DICE study where it studied the attainment of the goal in the Arab Emirates, Saudi Arabia, Lebanon, and Jordan, that in a very high-risk patient, 70% they are not achieving the goal. And we look at the data from Egypt for patients that present with acute coronary syndrome, and we give them high-intensity statin. The proportion of the patients that reach the goal in 4 months, they are only 6%. And when you look at the safest trial, there's a centralized pan-Middle East survey of under-treatment of hypercholesterolemia. You see that in patients with very high risk, that only 30% they are attaining the goal. And when you compare our findings with others from the different 17 guidelines and observational studies, you still have from the data of Arafat that 68% do not achieve the goal when the goal is 70. What about now when it has to be less than 55? This is a difficult issue. I think this would answer the current situation in our region and the gap in management. Thank you. Thank you.
Dr. Hani, you're on mute. Dr. Hani, can you hear us?
Sorry, I lost the signal for a second. So thank you, Dr. Tahir. This is a very nice overview. There's a lot of dense literature, obviously, from the Middle East, and it shows pretty much the same pattern, although I have to say that our knowledge from the Middle East is that the patients are younger, with a higher degree of atherosclerosis, more intense coronary artery disease, more frequent events, even though the age is younger. So I think the constellation of risk factors really behooves us to be very aware of this issue. Dr. Adil, I have a question for you. From your experience, what are the reasons for poor LDL attainment among our patients?
So, good afternoon, ladies and gentlemen. Thank you, Hani, for the introduction. So, before I embark on answering the question why the LDL goal attainment among patients is low, I would like actually to confirm what my colleagues, the other speakers, had just discussed. And I would like also to mention that dyslipidemia is quite prevalent in our region, and this has been discussed previously. So the prevalence, as you can see, has a wide range from 8.5 in the Ministry of Health survey in Saudi Arabia to 30% in the Gulf Race 1 and 2 to as high as ACE study to 70%. This wide variation, obviously, the causes of which are related to the study design, different population, and different time interval. Now, the issue is not actually that dyslipidemia is quite prevalent in our region. The achievement of LDL target, as my colleague has mentioned, that it is very low. For example, a study from Sultan Qaboos University Hospital have shown that only 43% of high-risk group achieve LDL goal, while in the CEPHEUS study, 32% of the very high-risk group achieved LDL goal. Now, this has been confirmed by the Da Vinci study, where actually it looked at the attainment of LDL goal based on the 2016 and 2019 guidelines. And as you can see that overall, 44% of population in the Central and Eastern Europe, they achieved LDL target versus 56 in the Northern Europe versus 60% in the Western Europe. This is if we consider the 2016 guidelines. Now, if we move to the 2018 guidelines, it is even worse. We are looking at 30 to 40% lower rate of attainment of LDL cholesterol. Now, the reasons why there is low LDL goal attainment among patients can be summarized into three factors: patient-related barriers, provider-related barriers, and regimen-related barriers. And these are really sort of interconnected and difficult to isolate one from the other. But if we look at patient-related factors, for example, therapeutic lifestyle changes like diet and physical activity, most of our patients, they would like to spend more in TLC in order to avoid taking medication. Patients can have poor adherence, and this is related to poor understanding of the treatment regimen. They don't really understand why these medications are prescribed. Why do they need to take more than one lipid agent? And sometimes the internet and the social media will give them a false impression. Furthermore, cost barrier is a very important aspect of failure to achieve LDL. Some patients, they cannot just afford buying these drugs. And there are other actually patient-related barriers, including negative experience with therapy or side effects, attitude toward the drug, misinformation by the media, cultural belief, psychosocial reason, cognitive impairment and forgetfulness, and complex dosing regimen. Now, speaking about the media, this is a very interesting study which was carried out in Denmark involving more than 60,000 patients taking statin. It has been shown that early statin discontinuation is higher when there is a negative nationwide statin-related news story, while the early statin discontinuation was much less if there is a positive nationwide statin-related news. And similar finding was found in the antihypertensive medication. The other aspect is provider-related barriers. Poor communication. Many physicians, during their busy schedules, they don't have enough time to explain the treatment regimen and why they are taking it. And even if they have the time, some physicians, they don't have adequate counseling skills for patient to understand. Lastly, there is regimen-related barriers. Some of our patients, they have multiple comorbidities and they will end up having polypharmacy with basically many side effects, and this will discourage them from continuing taking the drug. Also, starting at a low dose of statin and failure to up-titrate to achieve goals, and this is probably more related to physician's factor. And as I mentioned, sometimes occurrence of side effects will discourage patients from taking the drug. Now, this is actually a very interesting study which was carried out in 5 European countries in 700 primary care physicians as part of the REACT survey. And among the other questions, they were asked how a treatment can be improved. And 50% of the physicians interviewed, they mentioned that better patient education is associated with better treatment improvement. And this has been discussed in the DICE's study. We know that 50% they did not achieve LDL goal, but the predictors of LDL target achievement was as follows: higher statin dose, specialized treatment, and the combination therapy. And also from the Da Vinci trial, we found that the majority of patients were receiving moderately intensity statin, while in reality they should have received high intensity statin, and 28% of patients who receive high intensity statin should receive a combination therapy. So there is an issue here also with physicians not sticking to the guidelines. So how to sort out this issue? And this is the last slide, or before the last slide. First of all, educate and empower physicians on recent guidelines and implementation. And we have to shift from high-intensity statin to high-intensity lipid-lowering therapy. And also, we have to emphasize on the importance of therapeutic lifestyle change and nutrition. And interestingly, lipid clinics. And before I end up my presentation, I would like to share with you this slide, which is very interesting, comparing the lipid level outcome between pharmacist-managed lipid clinic versus the usual care. And as you can see, fasting lipid panel among patients who basically attended lipid clinic run by pharmacists were significantly lower than the usual care. Furthermore, the proportion of patients at goal in lipid clinic run by pharmacists was significantly higher than the usual care. Thank you very much.
Thank you very much, Adil. I think you've very scientifically actually tackled this issue of misinformation and disinformation. I think we'll go back to Professor Bush. Can you? I think you tackled it in the discussion, but if you could highlight some points on physician inertia and what we can do to close that gap.
Yeah, thank you very much. It is a critically important problem, and in fact, it is a nice continuation of the previous presentation, because we know it very well that despite we know that the statins are very effective, they are discontinued, as you can see in the slide, for primary prevention and the moderate to low intensity statin at about 15 months and 21 months for those treated with high intensity statin therapy. The problem is that we know it very well that those treated with low adherence to statin therapy are associated with the increase by even 75.4% of the risk. And we know it very well from these beautiful study published in European Heart Journal almost 10 years ago that no adherence is the independent new risk factor of the risk of cardiovascular disease. And if we are adherent to statin therapy, for example, we might reduce all-cause mortality by even 46%. So this is critically important. So how to overcome the physical inertia and non-adherence? One of the reasons is obviously the knowledge, both from the physicians given to the physicians and to the patients about the statin intolerance. Please have a look at our data published in European Heart Journal based on the data from 4.2 million about the statin intolerance prevalence. As you can see, the overall prevalence is only 9.1%. So 91% of patients can easily and safely be treated with patients. If we diagnose statin intolerance with the approval definition of National Lipid Association, International Lipid Expert Panel, the prevalence is even less, 7%. We should all know also about the risk factor that might increase this risk. So knowing about this is critically important, because if we know that chronic liver disease and chronic renal disease might increase the risk of the statin intolerance, we should simply optimize the treatment, and then we simply reduce the risk of statin intolerance. What is more, if something which is called nocebo or placebo effects, such as a kind of psychological approach that the patient will have statin intolerance, we should simply discuss with the patients those issues. We should use the information about the risk factors. We should use some clinical index score in order to have a causal link between the statin therapy and statin-associated muscle symptoms, and then we might reduce nocebo and placebo effect. And please have a look on our the first in the world recommendation how to overcome placebo and nocebo effect. First of all, it is obviously suitable step-by-step treatment, but please have a look something which is dedicated for the patient, so personalized intervention plan. So we need to simply educate the patients about the disease, about the treatment, what are benefits, what are potential adverse effects, and what about lifestyle changes, which is a critical point. What is more, if we would like to overcome physical inertia, we need to know how to stratify the risk of our patients. And please have a look at our definition of the extremely high-risk patients we introduced in 2021, because it is critically important that for those patients, we should use not only the target below 55, but even below 40. And finally, we have effective drug, however, we cannot use it. Please have a look at our data from Poland based on the 1 million people after acute coronary syndrome. And the problem is that if we first, we do not use high-intensity statin therapy. Second, if we add ezetimibe, we immediately reduce the number of patients being treated with the high-intensity statin therapy. And if we add PCSK9 inhibitors, we simply reduce high-intensity statin therapy and discontinue ezetimibe in many cases. So this is the largest problem, because if you would like to be on the target, you should take care of each step of the lipid-lowering therapy. And this is the results of our Odyssey price data to confirm you and convince that if we use ezetimibe as a part of the therapy, even 10% more of the patients might be on the target. So we cannot avoid this step in order to be effective. And finally, we should also focus on the suitable guidelines and the guidelines, and we should avoid such a guidelines which were presented by the ESC Prevention Guidelines 2021, in which the stepwise approach was suggested. It is the fake guidelines concerning this group of patients, because we know it very well that intensive, immediate upfront combination therapy for those patients should be recommended in order to be on the target. And finally, we should follow the guidelines we introduced in 2021. So for very high risk patients and extremely high risk patients, we should always start with the upfront combination therapy, because then it is the only chance in order to start the PCSK9 targeted approach only after 4 to 6 weeks if we fail, and another approaches, and then we to be simply on the target. And please have a look at our table from our guidelines, in which we simply give you the very concrete advice. If you recognize the risk of the patients, if you know the target which is suggested, recommended for those patients, if you know what is the recommended reduction or expected reduction of LDL cholesterol based on the baseline level, you will not make any mistake if you look on these combinations and if you use for your patient. And this is our last paper we have just published in last few weeks, please, last few days even. Please have a look that if we use combination therapy of high intensity therapy, ezetimibe, and even bempedoic acid and ezetimibe, we might have reduction over 85%. So we might overcome this physical inertia with the upfront combination therapy. And finally, do we have a data? Yes, we have. Please have a look that using combination therapy of statin and ezetimibe, we have even twice as much as many patients treated with the monotherapy on the LDL cholesterol target, and we might reduce cardiovascular outcomes based on the RACING trial and our recent data published in Poland based on the ACS Polish registry. After 3 years in those patients treated with the statins and ezetimibe, there was 47 reduction of the relative risk, and absolute risk reduction was 4.7%. So number needed to treat was 21. So every 21st patients benefited from the upfront combination therapy in patients after ACS. And finally, the innovative therapy. It is another issue and another response for physical inertia, because adherence to PCSK9 inhibitors based on ODYSSEA price data is 97%, and we expected to have even 100% adherence for inclisiran, and we know it very well based on the recent data published in European Heart Journal that it might be associated with the reduction of the cardiovascular outcomes by 25%. And finally, we need to certify the lipidologists. We need to have more and more lipidologists, as it was mentioned by my colleague, that if we have lipid clinics, lipidologists, then we increase the number of patients being on the target, and we should use discharge letter, in a very easy discharge letter, in which all the information about the treatment of the patients is given to the physicians, GPs, and the patients, and then we also might overcome the physical inertia and non-adherence. Thank you very much.
Thank you so much for that whirlwind tour. I'm sorry we had to compress a little bit because, but it's a fantastic discussion. I think a lot of teaching points there. Dr. Tahir, can you come back to this concept of how to use combination therapies to help more patients achieve their LDL targets in studies that show proven cardiovascular outcomes?
Yeah, thank you very much. I'll try to take the second part. So how to solve the problem of this gap is by using combination. And that has shown from early beginning that addition of non-statin will increase the percentage of patients achieving the LDL goal less than 70. And one of the best combinations is to combine HMG coredoxase inhibitors that reduce sensitivity of LDL together with an inhibitor of the absorption, which is ezetimibe. And simply look at 10 mg of ezetimibe plus 10 mg of atorvastatin is actually producing the same effect of giving an 80 milligram of atorvastatin. One of the studies that changed the practice and actually advocate the need to lower and lower the LDL was improve it, where ezetimibe was added to simvastatin in comparison of simvastatin for patient post-acute coronary syndrome. And the data was going to see the percentage of reduction of LDL, whether it is better with addition of ezetimibe or not, and the reduction of the MACE, major cardiovascular events from cardiovascular death, non-fatal MI, hospital admissions, or coronary revascularization. The data from IMPROVE-IT has shown that there is 24% relative risk reduction of LDL simply by the addition of ezetimibe to the simvastatin, and that was associated with 6.4% relative risk reduction in major cardiovascular events. The major benefit was in the reduction of non-fatal MI by 13% and non-fatal stroke by 20% without having an excess or an increase in the side effect or adverse cardiovascular effect, and safety endpoint was not a major concern. One of the important things that these kind of combination benefit groups of patients that include diabetic patients, it improved in high-risk patients without diabetes as well as the elderly. These three groups of patients benefit the most from the combination therapy. Another addition, and on the same time, the addition of PCSK9 in patients with acute coronary syndrome, where it shows further reduction in the LDL and a better cardiovascular outcome, like in 4 years in the patients with atherosclerotic cardiovascular disease and Odyssey in acute coronary syndrome. But in our region, there is no data on the current use of PCSK9 in the region. We see that the cost effectiveness of using this medicine are of global concern, and they never found to be cost effective in patients for primary prevention. And there is a prior insurance company approval, which is a concern. But I do believe that the high-risk patient benefit from PCSK9 as far as cost effectiveness is concerned. I mean, the diabetic cardiovascular disease, those with having associated kidney disease, and the baseline LDL above 100. And going to the latest in the market, which is targeting the RNA, targeting the synthesis of the PCSK9, and you can see the inclisiran shown in Orion 10 and 11 market reduction in the LDL, but still there is no clinical outcome studies until the present time. So I want to summarize what the LDL goals for a very high-risk patient. Now, I choose in the very high risk because we deal with acute coronary syndrome, atherosclerotic cardiovascular disease. We deal with diabetes that have both atherosclerotic cardiovascular disease together with diabetes. And I believe that the very high-risk patient, by definition, are those who documented atherosclerotic cardiovascular disease, whether imaging or clinically, and those with diabetes mellitus, with target organ damage, or three major risk factors, or early onset of type 1 diabetes with long duration. What the guidelines say, you have to reduce LDL by 50% together with attainment of LDL goal less than 1.4 millimole per deciliter. And in patients who experience a second vascular event within the 2 years, you have to lower it down to 40 milligram per deciliter. And the way you do that, first you start with high dose statin, and if 4 to 6 weeks you don't achieve the goal, then you add ezetimibe, and you don't achieve it in 4 to 6 weeks, then you use this patient as the PCSK9 inhibition. But if you perform a PCI in a patient with acute coronary syndrome, then you have to give a high intensity statin. And I want to, this is my last slide, that a few months ago in the American Association of Clinical Endocrinology, they mentioned about the extreme risk. And the extreme risk is when you have diabetes with an established cardiovascular disease and you have a target organ damage, like reducing eGFR by 45, or urinary albuminuria, or you have an LV systolic or diastolic dysfunction. They demanded in this group of patients that the LDL should be less than 55, and ApoB should be less than 70, and non-HDL less than 90. And in this kind of patient, again, you start with high-intensity statin, then you couple it with ezetimibe, and you fail to achieve the goal, the PCSK9 and the ATD. Thank you very much.
Right. Thank you very much, Dr. Taher. And again, last but not least, certainly, Dr. Adel, could you just summarize for us the modern concepts of lipid management and how to close the gaps in their attainment?
Thank you, Hani. I will just share my screen. So basically, I will just go through a practical and summary of the modern management of hyperlipidemia. And I can summarize them into 4 steps. The first step is to estimate the cardiovascular risk. The second step is you have to be familiar with the treatment target of LDL cholesterol. Third, the importance of lifestyle intervention. And finally, a drug therapy. So let us start with the first step. Now, estimation of cardiovascular risk can be performed as recommended by the European Society of Cardiology by estimating the score. And as you know, this table has 2 regions, the high-risk region of the Europe and low-risk region of Europe. And it can be also applied after certain modification to other countries. And as you can see, the variables here involve systolic blood pressure, total cholesterol, female and smoking status, in addition to age. And once you calculate the risk score, then you have to categorize patients into one of 4 categories: either very high risk group with a calculated score of 10 or more percent for 10-year risk of fatal CVD, high risk calculated score between 5 to 10, moderate risk more than 5 to less than 5, and the low risk is the calculated score of less than 1% for 10-year risk of fatal cardiovascular disease. And I would like to point out here that the score can be used to estimate the risk in patients who does not have a clinical atherosclerotic cardiovascular disease. But overall, if we look at the definition of very high risk, and I'm not going through the details of this category, but any patient with documented atherosclerotic cardiovascular disease, either MI or previous revascularization, then these automatically they belong to a very high risk, and you don't need to risk stratify them anymore. Diabetic patients with target organ damage, 3 or more major risk factors, or early onset type 1 diabetes of longer duration are also considered very high risk, in addition to severe kidney disease or a calculated risk of more than 10%, as I mentioned before. This will consider patient at very high risk. Now, the other categories, the high risk group and moderate risk group and the low risk group, as you can see them here in the slide, and I'm not going through them just for the sake of time. The second aspect of management of lipid, you have to know the targets. And as was discussed earlier by my colleagues, then we have to fit the target of LDL based on the score system that we calculated already. So those who belongs to the low risk group, we have to target LDL of 3. Moderate risk group, we have to target 2.6 millimole. The high risk, we have to target 1.8 millimole and 50% reduction from baseline. And the very high risk is 1.4, and we might actually consider giving lower in somebody who had another event within 2 years. And this is basically the table from the latest European guidelines, where they mention that in the secondary prevention patients at very high risk, an LDL reduction of at least 50% from baseline and LDL goal of less than 1.4 are recommended. And this is a class 1 level of evidence A. While in the primary prevention for individuals at very high risk but without familial hyperlipidemia, an LDL reduction of at least 50% from baseline and LDL goal of 1.4, and this is again a class 1 level of evidence C. For patients with atherosclerotic cardiovascular disease who experience a second vascular event within 2 years, and this event not necessarily of the same type as the first event, while taking maximally tolerated statin therapy, we have to achieve an LDL goal of less than 1, and this is a class 2B level of evidence B based on the guidelines. While in patients at high risk, an LDL reduction of at least 50% from baseline and LDL goal of less than 1.8 is recommended, and this is a class 1 level of evidence A. Now, we have actually to spend some time with patients to emphasize the lifestyle intervention, and we have to admit that our busy schedule prevents us from going through details of these intervention. And the guidelines actually spare a good amount of data on lifestyle intervention, but I will just summarize it in this single slide, that we have to advise patients on healthy diet, and this healthy diet, low in saturated fat with focus on whole grain products and vegetables and fruit and fish. We have to tell them about physical activity and what they should really do, and 3.5 to 7 hours of moderately vigorous physical activity per week, or 30 to 60 minutes on most days, are required. Also, we have to advise patients on the ideal body mass index, and this should be between 20 to 25, and the waist circumference in men should be less than 94, and in women less than 80. Lastly, drug therapy. Now, we have to understand the effect of each category of a drug in terms of their power to reduce LDL reduction. For example, if we use moderate intensity statin, then we expect to have 30% reduction in LDL, while high intensity statin, we are expecting a 50% reduction, while high intensity statin and ezetimibe 65, PCSK9 alone, there is a 60% reduction in LDL, while the combination of everything, PCSK9, high intensity statin with ezetimibe, we are expecting an 85% reduction. And finally, there are different actually drugs that can be used to treat dyslipidemia. Statin therapy obviously is the commonest. Then we have bile acid sequestrants, cholesterol absorption inhibitor like ezetimibe, PCSK9 inhibitor, and we have the novel, or maybe not novel anymore, in certain area I think that has been used, the N-glycerin, but the novel drug ATP citrate lipase or lyase inhibitor, bempedoic acid, we might have more data in the future. Thank you very much.
Thank you very much, Adil, for that excellent wrap-up. As usual, summarize it succinctly and very efficiently. So I think we only have one quick question. It's first of all, does statin cause weight gain? I think the answer is conclusively no. There is a possibility of new onset diabetes with high intensity statin, and that's usually restricted to patients who are already pre-diabetic, but still the benefit is far in favor of using statin in the high-risk patients with metabolic syndrome. There's another question very quickly from Dr. Anuj Jain from Bahrain. Which is the best risk calculator often used in practice to guide lipid management? So I think we don't really have a validated risk calculator in the region. And that's one of the problems we fall into. The risk scores here underestimate risk because they're heavily driven by age. So you know, and I know, we always have patients under the age of 40 and even 35 who are going for triple vessel cabbage, not really accounted for by any of the risk identifiers. So, you know, I think governments have to obtain their own Framingham-like data from our own populations, and I think we have a lot of resources to do so. In the interim, as you so nicely showed, we can actually do risk enhancement, calcium score, ABI, other things that help you to tell where the risk is. And then there's a question here, I believe. I'm sorry, I have to run through this very quickly. We're really much over time. When do you order an ApoB measurement? So I think the LDL, it's LDL, LDL, and LDL. I think it's very important to try and achieve the LDL goal. If you have achieved the LDL goal and your non-HDLC is high or your ApoB is high, then you can go a little bit further on the intensification of therapy. It's a very simple way of reassessing the particles without doing the expensive particle size test. And it just tells you can intensify some more in a particularly high-risk patient. Very last question is coronary calcium score. So there's a huge body of literature in coronary calcium score. I don't think we're going to be able to do it justice in the next few minutes, but you know, patients who have resistance to statin, they don't want to take a statin. This is the key use of this test. You send them for a calcium score, you show them the picture, hey, look, buddy, your arteries are dotted with calcium, you already have cardiovascular disease, what do you want next? You want to have a heart attack? It's a very efficient way of convincing the reluctant patient that they already have some established plaque, and it's a low-risk test, there's very little radiation, it's very safe, it's very cheap. I think the other where this is beneficial, if the there is a family history, but they don't fall into the familial hyperlipidemia. So they have a family history, but they don't fall into FH criteria by lipid profile. This is also very example, although there is a caveat, it doesn't cover soft plaque. So if it's not there, it doesn't completely eliminate the possibility of coronary artery disease. So I don't know if there's any final comments from the esteemed speakers. It's been a whirlwind tour. I think we had to compress a lot of knowledge in a short period of time, but I think we really hit a lot of highlights. If there's any other comments from Dr. Taher, Professor Banaj, Dr. Adil. So
I believe that we do not move to the networking lunch because we do not have time, because it's only 4 minutes left. So first of all, I believe that it is amazing that within an hour we were able to discuss so many important things associated with the effective lipid lowering therapy. So few points that I would love to remember, that please always focus on the upfront combination therapy, but always after suitable risk stratification. It is critically important because mostly we do not use suitable doses of statins. We do not use the combination therapy because our patients are underdiagnosed, in fact. And this is also the issue of the diabetic patient that was beautifully presented by Dr. Taher. Because for diabetic patients, we have a great problem, because still in the European guidelines, some patients with diabetes are treated or diagnosed as a moderate risk patients. It is not the true, because in the clinical practice, there is no moderate risk patients with diabetes. Because all those patients are with other risk factors, or the subclinical the atherosclerosis and the subclinical target organ damages. So that is why please always treat patients with diabetes those at least with high cardiovascular risk. What's more, that is why we introduced extremely high-risk patients, that also has been mentioned, because we know it very well that patients at the very high cardiovascular risk are a very heterogeneous group of patients, and that is why we cannot treat the same patients after one acute coronary syndrome in comparison to two acute coronary syndromes, on acute coronary syndromes versus acute coronary syndrome with diabetes and other risk factors. So please always do not think about in fact the target. Please try to be as low as possible with LDL cholesterol. And one last point, but critically important, because I am very much focused on the statin intolerance. Do not think about the statin intolerance while you are starting statin therapy, because if you think about the statin intolerance at the very beginning, you will be not adherent and you will have physical inertia from the very beginning. So this is my last comment. Thank you very much once again for the invitation.
Terrific. Thank you very much for those comments. Very practical clinical application. I think, I don't know, do we have any more time, or are we way over? We have a couple of minutes.
Yeah, I think we have a couple of minutes to close, or just 1 minute to close. So on behalf of all of us, Dr. Hani, Dr. Banak, Dr. Taher, and Dr. Adil, we would like to thank you tremendously for your contribution. I know this panel can last for hours and hours, and we will all be very engaged and enthusiastic about what is presented, because as again, this therapy area is rapidly evolving, and lots of doctors are doing so little for their patients. So this is really informative. This is really educational for everyone. So on behalf of myself and all of us at Organon, we would like to thank you so much for your participation and contribution. And for those who are attending online, we will move now to the second session. So please stay with us because we will continue the discussion around this lipidemia. Okay, thank you so much.
Thank you. Thank you very much. Thank you. Bye-bye.
Thank you very much. Great presentation. Thank you very much.
Thank you very much.
So hello again, everyone. I'm Michael Sadiq, medical advisor from Organon. I'm your host today for the cardiovascular sessions for the day. So we started with a very good panel discussion talking about the dyslipidemia management and the current gaps and the educational needs for everyone. And now we're moving to another very interesting topic, which is related to the best approach to dyslipidemia management. And it's going to be like pros and cons of each scenario. So we have like 3 eminent international experts with us who will be moderating and speaking in the session. So it gives me great pleasure to introduce Professor Khaled Al-Rasadi. Professor Khaled Al-Rasadi is the Director of Medical Research Center in Sultan Qaboos University. He's a Professor of Biochemistry, College of Medicine and Health Sciences, and Consultant Lipidologist at Sultan Qaboos University Hospital. And he's also the President of Oman Society for Lipid and Atherosclerosis, the OSLA. So today he will introduce us to the topic of this interesting debate. So without further ado, Dr. Khaled, the floor is yours.
Thank you very much, Michael, for the kind introduction. So good afternoon, everyone, and thank you very much for the Organon to support this educational grant. And so this session really will be about the different approach to the dyslipidemia management, and we have 2 eminent speakers and very well known in the field of cardiovascular prevention and dyslipidemia management. So I will introduce the first speaker, Dr. Hani Raji. He's an attending consultant cardiologist and head of department at the National Heart Institute. He's a fellow of the Society of Cardiac Angiography and Intervention, FSCAI USA, and the European Society of Cardiology. So Dr. Hani is going to lead the talk about the intensive LDL lowering, which combination medication upfront. It's now or never. So it will be a 15-minute talk, and then it will be followed by a 5 minutes question and answer. So I will advise the participant, please put your question at the chatting bar, and we'll be happy to convey your questions to the speaker. So Dr. Hani, the floor is all yours.
Thank you very much, Dr. Khaled. Thank you for the very kind introduction, and I'm honored to be here today. And I'd like to thank Organon and the organizers and the technical team, which helped me a lot. Because I also tend to go completely over time and talk for 22 minutes when I'm allowed only 15. So we actually put my presentation in a recording, which still spilled a little bit over time, but less than 1 minute. So we're gonna put the recording, but that also helps avoid internet glitches in Cairo, which are common in Cairo on Friday because of very heavy traffic. And then, but I'm available, I'm attending live, and I'll be happy to answer all the questions live. Dear Michael, dear colleagues at support, please play my recording. Morning. My name is Hani Raji. I'm a cardiologist from Egypt, and I would like to thank the organizers of the Oscar meeting for bringing us together today. And in the next few minutes, I'm going to discuss intensive lipid lowering as the key to cardiovascular disease protection, and also I would like to show how urgent this is. It's really now or never to reach our new target levels. This is just going to be a frame of what we're going to discuss today about LDL and cardiovascular risk and the new guidelines and how we can reach targets and how we can reach targets efficiently and quickly. I don't need to remind you that cardiovascular disease is the #1 cause of non-communicable death globally. And I'm actually the president of the Egyptian Society of Non-Communicable Disease, prevention and very, very aware of this. Cardiovascular disease is the biggest killer, even bigger than infectious conditions like COVID, which took the world by storm, and than anything else. And LDL is the causal, high cholesterol and high LDL. From many studies that we've seen, this was nearly 1 million patients who were analyzed, and we know that the total cholesterol and the high cholesterol and the high LDL are linked to cardiovascular disease and other cause, and especially in patients with who've been exposed all their lives, like the heterozygous FH patients who developed cardiovascular disease, 2 decades before people without high cholesterol since birth. We also know from epidemiological studies that modern hunter-gatherers with low LDL, like some tribes in the Amazon, have very little atherosclerosis, and we also know of studying of over 300,000 people looking at PCSK9 gain of function or loss of function alleles, which determine if your LDL is high or low since birth. But if you're lucky and you have a loss of function allele and your LDL is low since you were born, you actually are protected from atherosclerosis and coronary heart disease. While if you're unlucky and you have a genetic gain of function, PCSK9, then your LDL is high since birth and you get coronary heart disease a few decades before. So lifelong LDL has been shown in many publications, including this meta-analysis of over 300,000 people, to when you're exposed to natural level But if you're lucky and you have a loss of function allele and your LDL is low since you were born, you actually are protected from atherosclerosis and coronary heart disease. While if you're unlucky and you have a genetic gain of function, PCSK9, then your LDL is high since birth and you get coronary heart disease a few decades before others. So lifelong LDL has been shown in many publications, including this meta-analysis of over 300,000 people, to when you're exposed to natural levels of LDL due to genetic polymorphism, you get less coronary heart disease. The risk of coronary heart disease is reduced by more than 50%, each millimole per liter lowering of the LDL over life. We also know that the degree of LDL reduction by statins was associated with reduced risk to cardiovascular events. patients would benefit from possible starting with something more than statins. High-risk patients with poorly controlled LDL, despite being treated, of course, you need to up-titrate. Those who are unable to take the full dose of statins for multiple reasons, or familial hypercholesteremia. The current standards of care fail us many times in lipid lowering. Why? One of them is for many younger patients, they don't like to take pills and they over-rely on diet and lifestyle changes. They don't realize the impact their genetics are having on their coronaries. Many doctors start with insufficient starting doses of statins in a sort of shy way. And then there is a lack of follow-up for up titration. So many patients are lost. And we know from data that the majority of patients get left on their starting statin dose or their starting combo dose. There's complacency and inertia, and there's a lot of confusion about recommended lipid targets. Of course, there's some rumors and ungrounded fears about the effects of statins, and there is the very rare true statin intolerance. And the new treatment options, of course, is the injectable.
What do you see over there?
Where? I can't see it.
Are you sure?
Oh, I see now. It's a castle, a big castle.
Romeo and Montague, the only son of your great enemy.
Look over there.
Where?
There. It's a
has required an artificial pacemaker to direct send electrical impulses to her heart.
Do you see anything else? What else do you see?
I see.
Pero
I see.
أنا شايفة.
Je vois. I see.
I see.
At Organon, we see her future. Our vision is a better and healthier every day for every woman. We believe by listening to women and focusing on innovation that address their unmet needs, we can realize a future as unlimited as her imagination.
we received yet any questions, but do you mind to give us maybe a summary of like one minute of your take-home message for starting the combination therapy or the combination pill as you describe it?
Thank you very much. Yes, and I'm very sorry about the technical glitch in the recording. I just sent an email objecting. I was not told that there was any issues. That I was available today. I could have easily presented it without glitches. Anyway, I hope the slides were clear at least. The point is that now with the change in the targets to include many different risk categories, and some of the patients who don't seem to be at high risk, for instance, diabetics who have been diabetic for 25 years, or patients who find 60% carotid stenosis asymptomatic on a duplex, all those patients have to go down to targets of below 55, which also includes about 1 in 250 of all humans who have heterozygous familial hypercholesterolemia. It's estimated that the number of people with an LDL of above 190 in healthy people who are walking around is about 120, is 1 in 250. All those people are unlikely to reach the targets with the first low dose of statin. So if people give them, like 10 milligrams of whatever, and then retest them in 6 weeks and find that they haven't reached the target, so they give them the highest possible, are unlikely to reach the targets with the first low dose of statin. So if people give them, like 10 milligrams of whatever, and then retest them in 6 weeks and find that they haven't reached the target, so they give them the highest possible dose of this particular statin, and then retest them again in 6 weeks, and either find that they have reached the target or they haven't reached the target, and then they change. We face two problems here. The first problem is a patient-related problem, which is that the patients might not do very well with this sequential raising of the dose. It scares them. It gives them an impression that the condition is more difficult to treat. It's obviously better for the patients because patients see their numbers and they get told. It's obviously better for the patients to reach their target treatment from the first attempt. They will feel that they're even being treated by a better doctor, especially in private. So, and the other option is in physician inertia or in patients who live away, who simply take the first pill and they leave and they think they have a treatment for the cholesterol, and then they're not really followed up or not up titrated. So our point, many of us in those high-risk patients, we suggest, based on the current data, which shows that it's safe and effective and more event reducing, to start with a combo pill with moderate intensity statins and ezetimibe, and even in the highest risk patients who have an LDL of 200 plus, even with a high intensity statin and ezetimibe combo pill. And that way, you will get rid of so many problems at no penalty. No penalty, unless in your own community there's a major difference in cost issues. But for instance, where I practice, there's no penalty in starting with no penalty for the patient, no penalty for the doctor, no penalty for the system, all advantages. And it's not really outside the guidelines. The guidelines do recommend it as a second step, and we know that the majority of such high-risk patients will need the second step. That was the summary of my presentation.
Thank you, Dr. Hani. There's we have maybe another 2 minutes. There's a question regarding this combination therapy, and are we expecting more muscle pain, more myalgia, and so in this case, what should we do? Should we break the combination therapy, because we don't know with this combination, is it the statin, is it the ezetimibe? So what's your
thank you very much. Yeah, I can read the question. Actually, ezetimibe has not been reported to cause any muscle pains, and we do know that the majority of muscle pains on statins are not actually caused by the statin as well. But that is not something that patients believe. So if a patient comes with muscle pains, in my practice, I discuss with the patients and I assess the risk. And in a worst case scenario, I'll go down to the lowest combination of the lowest dose of statin. So for instance, if I'm using an atorvastatin ezetimibe combination, instead of 80 with 10 or 40 with 10, I'll go down to 10-10. And many of the patients still stay on target. And then we can up titrate gently if they haven't. And the same with Rosuva. I'll go down to 5-10. So, and you know, obviously if the patient is totally intolerant regarding muscle pains, and if the patient knows that they're in a high risk group and that this is a life-saving drug, but still says, no, I don't want to take it, that's the true statin intolerance, whether it's physical or psychological. Because a truly psychologically patient who will just not take statins, even if you believe as a physician that they're imagining them symptoms, which is the worst case scenario, you still have to comply with the patient's wishes. So of course, there are the true statin intolerance. In all cases, we now have the injectable drugs, we now have the PCSK9, and we now have the inclisiran, which such a patient can take an injection every 6 months and do really well. But yes, we will actually, you know, if we, especially if we have objective evidence like a high CK, we will actually reduce the dose of the statins and rely on the combo. And with this kind of combo, you're more likely to reach the target with a lower statin dose, as the last paper I showed in my presentation pointed out.
Great. Thank you very much, Dr. Hani, for you know, highlighting this topic and all this issue. And I hope you will stay with us to listen to the next speaker. So now it will give me the pleasure really to introduce Dr. Walid Al-Dhahi. Dr. Walid Al-Dhahi, he's the head of Kuwait Diabetes Society, and he's a consultant endocrinology and diabetes at Mubarak Al-Kabir Hospital. And he's also a visitor consultant endocrinology and diabetes at Kuwait Oil Company Hospital. So Dr. Walid will present the other side of lipid management, which is, you know, we see it in most of the guidelines, either the international or the local even, so which is the stepwise starting of lipid treatment in managing of these patients with high atherosclerotic cardiovascular disease. Dr. Walid, the floor is yours.
Assalamu alaikum. Masā al-khair jami'an. Thank you, Mr. Chairman, for your kind introduction, and thank Organon for involving me in this interesting talk about lipids, and thank you, Dr. Hani, for your great lecture. I'm just going to start to... Okay. So my job is to talk about what's written in the guidelines about. I hope you hear me.
We hear very well. Do you manage to play the slides?
See my slides?
Yeah, we see you. We see it. Yeah.
Yes. So, thank you. So when we talk about cardiovascular disease, this is just to show you that cardiovascular disease is one of the most important diseases that happens in the world, and also in our area, in the Gulf. We are in the top 10 causes of death is cardiovascular disease. So we are suffering from cardiovascular disease and dyslipidemia. And unfortunately, we have high unmet needs, especially people who are at high risk. And you can see here that people who have recurrent cardiovascular events are more, you know, severe and costly compared with the people with the first events. And the people who already have event before, their survival rate, their cost is very high compared to people who have the first events. And also, nearly 1 in 5% of my patients will have recurrent events. So this is a disease that is staying with us, as Professor Hani was saying. This is a very aggressive disease, a cardiovascular disease, and we see that every day in our area. When you look at the real-world evidence, the real-world evidence is actually showed even more, prevalence of, MACE rates compared to what we see in the randomized trial. So this is just to show you how big is the problem that we are facing. Now, LDL is the focus of our treatment, and we know that for many years people are actually still even in the Gulf, some doctors were saying that cholesterol is not important and all of this that have no evidence. But now we know that LDL is our major risk factor, and it's our major target in management of cardiovascular disease. So this is just to show you how important LDL is. Now, if you look at the trials over the years using different modalities, we know that the lower the LDL, the better overall for our patients, and this is proven by different modalities and different randomized trials. And over the years, we know that even the guidelines have been lowering LDL because of the availability of evidence, and also because of the availability of medicine that can lower LDL to a safe target, as you can see here. So we still are waiting for more even evidence to manage this kind of LDL and also other lipid modalities. And LDL is correlated very well with reduction in cardiovascular disease, and this is clearly shown and clearly proven with each millimole or 39 milligram reduction in LDL over 5 years. There is association of a greater risk, around 23 risk reduction in major coronary heart disease and 21 risk reduction in major vascular events. So this is just an introduction to show you how important is the LDL with the cardiovascular disease, and over the years the guidelines actually translating this information, as you can see here from when you look at insufficient control with the maximum dose of lipid lowering therapy is actually one of different causes, but most of the time the doctor's just attacking that the drug is not working, let's go to another. And that's the reason why sometimes even with the combination therapy we don't reach actually our goal, because the patient is not opting a lifestyle that actually translates better with his general condition. And also some doctors are not basically adjusting the doses according to the patient needs. So there are several factors, not only failure of medication. This is one of the what we call the physician inertia. This is a very interesting study. It's a very old study in 2000, but I always like to use it in my slides. And this is basically where they went to the physicians and they asked them about the awareness of the guidelines. And you can see here 95% are aware of the guidelines, but when they open their files, actually only 18% they translate the guidelines into their action. So provider awareness does not equal successful implementation. And this is one of the big issues we are facing in the management of dyslipidemia and also other diseases like diabetes and the others. And this is basically where the focus of most of the guidelines, where you don't only think that there is failure of medication, there are other reasons you have to think about when you manage dyslipidemia. Now, when you look at the guidelines or recommendations and advice about lowering LDL based on cardiovascular disease, we know that there is very high risk and high risk, and that the guidelines have been little bit changing over the years by definitions of what is high risk and what is very high risk. I'm sure you all know this. I don't have to read it for you, but in the guidelines, statins are universally recommended as a first-line therapy across the whole guidelines, followed by ezetimibe and then BCAAs. So this is basically what most of the guidelines said. So stepwise approach is the focus of all the guidelines we have. ESC, American College of Cardiology, American Heart Association, AACE, ADA, all of them, they insist on stepwise approach. And that's not because this is just basically a coincidence. No, it's because the evidence we have is basically support this. We don't have good evidence, although there are small studies, and Dr. Hani mentioned some of them, but there is no good randomized evidence saying that you need to give multiple medications at the start. The logic, but doesn't really prove. And in medicine, we don't go with logic, we go with the proof. That's why whole guidelines, they go with the same idea, stepwise approach in the management of dyslipidemia, aiming at intensive risk factor treatment. So it's not only lipids, it's risk factor treatment. And in 16 it was May, and then now it is basically a fact that we can use. And that's why we have this kind of segregation of our patients according to their risk and according to their need of aggressiveness. I do agree with Dr. Hani that as a very high risk, we tend to need to be more aggressive, but that's why the guidelines is basically based on evidence that had to put people into different groups so they can actually manage and reach the level of LDL. Not everybody needs an LDL of 1.4, and that's probably one of the misleading ideas that the doctors are using. I have all these medications, let's push my patient to 1.4, and the patient doesn't need that because he's not in this group of risk. So this is basically why the guidelines is very clear. This is the guideline from AAS, you can see this is just a scream of the guideline, and ezetimibe is added after the use of statin. Let's go closely, and this is basically the guideline. Total cardiovascular assessment, baseline LDL, indication for drug therapy, then you go for, if you need to go for therapy, you use high potency statin at high recommended rate, or you can, if they have low risk, you can go with lifestyle modification, and then you add ezetimibe. If the LDL don't reach, then you follow up annually. If not reach, then you go with BCAAs. So the guidelines is very clear in this. And this is basically, we move now to 2018, American Heart Association, and you can see here that again, statin therapy should be initiated or continued with the aim of achieving 50% target. There is no mentioning of early combination therapy. And then for people with less risk, you can use moderate intensity statin. Again, this is secondary, that was primary prevention. This is secondary prevention. You should include maximum tolerated statin and ezetimibe. So basically, this is also a move with more aggressiveness. You still have to have the stepwise approach as you can. See here. Again, this is the 2018 guidelines. This is the primary prevention. I'm not going to read it, but just to show you. 2021 up to the highest tolerable. Many doctors, they just thinking about, manipulating the dose, thinking about other causes that may cause side effects, as we all know. For secondary prevention, patient not achieving their goal, maximum tolerated dose. So this is basically the stepwise approach is emphasized in 2021, and then you add ezetimibe and combination therapy and PCSK9. Let's look at the American Diabetes Association, the 2021 standard of care medical practice. Let's see what they say. For patients of all ages and diabetes, atherosclerosis, cardiovascular disease, high intensity statin therapy should be added to lifestyle modification. So then, in the second line, you can see adding ezetimibe and PCSK9 may be preferred. PCSK9 because of the causes may be preferred. So, ezetimibe. So basically, in the ADA, they still concur on the stepwise, concur on managing statin with high dose, and then use ezetimibe as a second line, and then PCSK9. The AACE, which is basically 2020, this is consensus treatment of the American Association of Clinical Endocrinology, and you can see this is from their guidelines, and you can see they put them at extreme risk, very high risk, modest risk, and low risk, and the lipid management. And you can see here lifestyle high intensity statin is basically the starting modality in the management of dyslipidemia. And then if you don't reach, you add either PCSK9 or ezetimibe, as you can see here. So basically, this is something that is concurred in all the guidelines that you have to do with the stepwise. So stepwise approach based on guidelines, all the guidelines adopt the same idea of stepwise approach, and this is because it's more practical, it's cheaper, it's based on evidence, and also give opportunity for doctors to use the medication in the proper way and not to jump to another class without the need. So risk stratification is step one, very important, and this is one of the major flaws in our system. We see in our doctors that they put everybody in the same basket, and then they say everybody needs to take PCSK9. This is wrong, and this happens in Kuwait too. We have very heavy movement to use of PCSK9 without indication, because of this aggressiveness idea. Every doctor is now pushing to be more aggressive. They say, I'm going to save my patient without looking at the category. Lifestyle and statin is going to be a step two, which is very most important step in the management of dyslipidemia. Add ezetimibe, add PCSK9, and then meet LDL and non-HDL goals to achieve atherosclerosis risk reduction. So this is basically the all guidelines concur on the same idea, as you can see here. So LDL reduction, it is difficult. We know that 75% of patients with atherosclerosis did not achieve target and LDL, as Dr. Hani also mentioned, put a similar idea. But this is telling us not to go more aggressive, to go more actually wise and use our medications in the proper doses. We fight inertia, we advise lifestyle modification, and then we move to the other class. And this is where we have to manage our patient. It's not only lipid modification, lifestyle, blood pressure, glucose monitoring, all of these actually will lead to cardiovascular disease. So it's not only putting your all emphasis on lipid modification, you have to think about your patient in a more thorough fashion. Now, the ticking clock hypothesis, which basically happens to most of our patients with micro and macrovascular disease with diabetes. You can see that macrovascular disease starts even before the diagnosis of hyperglycemia. So more meds, more cost, more side effects does not really help if you actually don't start very early in the treatment. So managing our patient very early, identifying the patient that need to be managed at high risk very early in their journey in this disease is more important than pushing more medications to the patient. So in summary, LDL is the main target. Failure to achieve target is multifactorial. It's not only failure of medications. Stepwise approach is persistent in all guidelines. Early combination therapy could lack evidence. We don't have big evidence, more expensive, probably can also add more side effects. So we have to be wise and use it in particular, as Dr. Hani was saying, maybe some particular patients we need to be very aggressive, but most of the dyslipidemic patients, they don't need to be aggressive in the stuff. Thank you very much.
Thank you very much, Dr. Walid, for this comprehensive review of the evidence for the stepwise using of lipid lowering in the management of patients with high risk. I'm still waiting for questions to come through the chatting icon. Till that time, maybe I can ask Dr. Walid. So you beautifully thought about the stepwise, and how about if we from the beginning that we know that these patients are really at very high risk, and like you beautifully had summarized, the different studies showing we are aggressively going lower and lower with the LDL cholesterol target. So for patients with MI and another MI within 2 years, they propose that you go even to at least 1 millimole or around 44. So starting, even with high intensity statin in these patients, we know, from the observational study that usually they it's very, very difficult really to bring them to that low. So in this case, I mean, will that change the view that we need maybe another combination therapy? I mean, in those only special patients?
Yes.
What do you think?
I do agree, and I agree with Professor Hani and his few last slides where the very extreme high risk patient, probably you need to be more aggressive at start. And still we don't have evidence for that, but logically, and there are some papers going out here and there that showed that probably it's much better, compliance is better, and reaching target is faster. But the issue here, we're not talking about these few patients out of the whole dyslipidemic population. And unfortunately, these facts has been translating to all patients with dyslipidemia, and they said, what are you losing? Be aggressive. But my question is, if I have a patient who's, let's see, moderate or very high risk, not very extreme risk, and he don't have payment to cover his hypertension and his diabetes and his proteinuria, and I just want to push more lipid management, does that really does the evidence help you to do that? It actually goes against you. So the idea here is that you have to use these medications wisely because of the expensive nature, and also because there's no evidence that you can use, if you use them earlier. You lower LDL. We have for many years. The most famous example is digoxin with the DITCH trial, 7 years follow-up. Everybody احنا نقول يحلف براس digoxin that it will improve heart disease, but at the end it's just symptomatic, does not really improve mortality after the trial. So we are here as scientists, we need evidence, and also we are smart enough to use the evidence available to help our patients. But my idea is not going against Dr. Hani. Of course, I totally agree with Professor Hani, but we don't have to put this for everybody. And that's the problem. Even in Kuwait, for example, where PCSK9 are giving free of charge for locals, now everybody is on PCSK9. Is that really what we want to do?
Yeah, great. So beautiful answer. So do you think then maybe implementing what we call a risk stratification in patients with secondary prevention, or those patients with extreme risk, will help to guide at least where we should put our money, like you say, because it is a cost at the end. So we should put our money, especially in those patients, from the beginning, from a policy make a decision. So do you think that will be useful?
Yes, I totally agree. I think, especially in countries where there is a system and patient is followed, and there is online services where actually patient, once he's seen by cardiologist in the CCU or ICU, he should be labeled with a level of risk, and based on that, basically everybody will follow. Here we're talking about public services where the service is given for free, and you cannot manage free service by loose ends. You have to be very tight because you want to help many people. And we are in the MENA region, and I'm president of Kuwait Diabetes Society. We meet a lot with the MENA region. We have in our colleagues in our neighbor countries, they have even difficulty in taking enough doses of statin itself. Rather than use of ezetimibe and PCSK9. PCSK9 in some countries like a dream. So risk assessment is very important. Using your tools is like, you are in a war and you have limited, forces, and you have to use your forces in the right places. So if I have very extreme risk, I will give him, but if I have somebody with low risk, I don't have to give him. And that's happened in Kuwait. We have PCSK9. We've been using it. It's been open a little bit more. People are now giving it to everybody. Now we don't have PCSK9 because the drug is not available, and now people who need it, they don't have it.
Thank you very much, Dr. Walid. I think we can conclude here. I would like really to thank both Dr. Hani and Dr. Walid for this excellent debate, and it was really very nice to exchange thoughts and the ideas, and I hope that the participant side had taken the message that really the use of the combination therapy is really needed, but you need to look for the right cohort of patients, especially those with very high risk or extreme risk, for more cost benefit of this treatment. So with that, I think we will end. Michael, over to you if you want to.
Yeah. So thank you so much, Professor Khaled, Professor Walid, and Professor Hani. This was really interesting to see the different opinions, different points of view. And as you said, it's like a spectrum of patients, and you can allocate your treatment according to the type of the risk, according to the patient profile. And as you said, like it's again a complementary points of view, not just like either or. It's like both can be applied in different scenarios. And this is what's really great. And now we are blessed to have like this whole spectrum of armamentarium of lipid lowering drugs that can suit different patient profiles, starting from the low risk or to like the extremely high risk patients. So the clear message is that we can get patients to target, of course, as long as you know the tools and you know where they want to go. So on behalf of myself and the whole Organon team, we want to thank Dr. Khaled, Dr. Walid, and Dr. Hani for your valuable contributions. We want to thank all the online audience for your presence, for your interaction and your participation. And we will move now into the third session in our dyslipidemia track, which is talking about women and cardiovascular disease. So for those who are attending online, stay with us, don't go away. And we will see you again in a couple of minutes for the next session. Thank you so much and have a good rest of the day.
Thank you very much. Thank you, Dr. Hani, Dr. Walid. Thank you very much. Thank you.
Thank you very much. Goodbye.
Bye-bye. providing a better and healthier everyday for every woman, one of the really important issues for us to talk about is the women in each therapy area. And of course, cardiovascular disease is one of those most important areas. So today we're talking for the first time in Organon about the women and cardiovascular disease. And to start with that kind of dialogue, of course, we have two eminent professors with us to talk about the cardiovascular disease specificities in women and how we can close this gender gap. So we have with us today from UAE, Dr. Juwairiya Al-Ali. Dr. Juwairiya Al-Ali is the president of Emirates Cardiac Society and the consultant cardiologist in Rashid Hospital. And we have Dr. Nerina Okesha. Dr. Nerina Okesha is a professor of cardiology in Ain Shams University, Cairo in Egypt, and she's a fellow of the American College of Cardiology. So today we're having a kind of an interesting dialogue with those two experts about cardiovascular disease in women. And we will start with the first question to Dr. Nerine. So Dr. Nerine, can you please share with us like the recent data regarding the prevalence of cardiovascular diseases in women, and how does that impact the morbidity and mortality for women across the world?
All right. Thank you, Michael, for the introduction. I hope this session is going to just try to highlight the gap between males and females in cardiovascular disease and in the different lines of management. I'll start by sharing my screen right now. Okay. Now, can you see my screen?
Yes.
Yes, okay. Let's see. As we all know that cardiovascular disease is the #1 killer of men and women. The coronary heart disease, the MI, the acute coronary syndrome, accounts for more than 50% of the cardiovascular deaths, followed by stroke, heart failure, and high blood pressure. And this is both for men and women. It was once believed that women are immune to cardiovascular disease, but this has proven to be wrong. Let's see some facts about cardiovascular disease in women. Cardiovascular disease kills more women than all forms of cancer combined together. Among females at the age of 20 years or older, nearly 45% are living with some sort of cardiovascular disease. Cardiovascular disease is the #1 killer of the newborns and accounts for over 1/3 of the maternal mortality. Less than 50% of women entering pregnancy in the United States have good heart. This means that more than 50% are having a heart disease during their pregnancy. Premature heart disease versus premature cancer. While premature cancer death continues to decline, premature heart disease death increased after 2010. The mortality gap between premature cardiovascular disease and premature cancer is narrowing over years. Cardiovascular mortality in women on the rise again. They found that during the era of 1999 till 2011, the mortality from cardiovascular disease in women have declined by 23%. But unfortunately, and we don't know why this happened, but the mortality raised by 7% in 2017. Women have slightly lower incidence of cardiovascular disease than men, but if they have cardiovascular disease, they will have more mortality than men. 38% of women experience a heart attack will die within 1 year, compared to only 25% of men. 35% of women with a heart attack survivor, they will have another heart attack during the first year, compared to 18% of men. Women have bypass surgery, they will die twice as much as men. Okay.
So thank you so much, Dr. Nerine. And again, this is kind of an eye-opener data showing us that there is a very big gender gap in the morbidity and mortality of cardiovascular diseases, which it needs all of us to act together to address this issue. So Dr. Juwairiya, coming to these gaps, can you please describe in more details the current gaps and the treatment disparities between men and women in cardiovascular disease?
Sure. I mean, the gaps in cardiovascular disease happen not only in the therapy, but also on the presentations. Women are more likely to have atypical chest pain or non-anginal pain, which makes them less likely to be recognized by a physician. And often, women in a younger age, because of the misconception that women are unlikely to have coronary artery disease, they're more likely to be unrecognized, and usually their presentation is more complex. So they usually present with an acute MI or heart failure or sudden death, which is different than the presentation for men. And generally, coronary angiogram in women doesn't show evidence of atherosclerotic coronary disease because the problem is in the microcirculation. So they often get dismissed by the physician because they think, well, the coronaries are normal, so this is not cardiac, but that's not true. And then given that they have higher prevalence of cardiovascular risk factor, they're more likely to be excluded from trials. So women are underrepresented in the trials. And this is a major problem because since the cardiovascular risk in women is under-recognized, it's under-recognized both with physicians and with women themselves. So less than 50% of women knew that the number one killer for them is cardiovascular disease. And usually women are embarrassed by the issue of cardiovascular disease because they think it's related to weight. So they think it's their problem. You know, they caused this to themselves, which is not true. There's lots of risk factors related to cardiovascular disease. And the other problem is cardiologists or general GPs, they are uncomfortable assessing cardiovascular risk in women. So that leads to disparities. So what disparities do we see? So we have seen disparities in the Gulf countries. So this study looked at patients with high risk and very high risk atherosclerotic cardiovascular disease and whether they achieved their targets. So in this study, average age was 57, which of course younger than the age in the Western population, and 40% of patients were women. So that's a good representation of women. And we saw that women were more likely to be diabetics and more likely to have metabolic syndrome compared to men. Also, women were less likely to achieve their LDL target or HDL target or ApoB target compared to men. And this gap was even higher in women with a very high ASCVD risk score. So they were even more unlikely to achieve their targets of LDL or non-HDL cholesterol or ApoB. And this is similar to what we see in the Western countries. So this is the Sweden registry, a Sweden heart registry, which looked at patients who had a presentation of acute MI within the past year. And they found out that women were less likely to achieve their LDL targets compared to men. Also, they were less likely to achieve blood pressure target compared to men. We saw the same thing in the Virgo study analysis. So younger women with MI had higher risk of cardiovascular risk factors. They have higher rates of depression and stress and poor physical status overall. And they usually present late with a higher risk score. So their presentation of acute MI is of higher risk, and they are less likely to undergo revascularization, which is a major problem because we understand that revascularization, time is myocardium. So if you don't undergo revascularization, you're losing precious time and you're losing precious muscle, and women were less likely to achieve that. So if we look at this population-based study in Spain, women who presented with acute coronary syndrome, so these are patients who are identified as acute coronary syndromes, they're less likely to receive all the therapies that we know that are good for the heart. So less likely to receive aspirin, less likely to receive P2Y12 inhibitors, oral anticoagulants, ACE inhibitor or ARBs, beta blockers, and statin. And the same was found in the Sweden Heart Registry as well. Women were less likely to receive all of these therapies, and they were less likely to receive reperfusion therapy as well. The only thing that favored women were more likely to receive nitrate, which we all know nitrate has no mortality benefit. It was only symptomatic therapy. So, and there is also a sixth difference in the pattern of prescription of a statin. So this is from the United States, looking at patients who presented with acute MI between the year 2007 and 2015. And we see that women were less likely to be initiated on statin and were less likely to have low to moderate intensity statin. There was some difference in high intensity statin, maybe not statistically significant, but it was less in women than men. So these are the discrepancies that we find between the treatment of women and men. So I'll hand it back to you, Michael.
Thank you so much, Dr. Juwairiya. And as we dig deeper into this topic, we see the gap in different aspects, like in different areas of cardiovascular disease. And that brings us to the next topic, which is the risk factors. So, Dr. Nareen, we want to examine closely and to understand, do women have specific different risk factors than men? I mean, like we have the traditional risk factors, and nowadays there is an ongoing talk and debate about the non-traditional risk factors specific for women. So can you please give us more data into this topic?
Okay. Just a minute. Okay. خليني ألخص القصة بتاعتنا هتمشي إزاي. Now we have the common risk factors. Common risk factors are the risk factors for cardiovascular disease in both men as well as women. We all know about them as the age, hypertension, hyperlipidemia, smoking, diabetes, high density lipoprotein, sedentary life, obesity. All those are the risk factors for both of them. But do these risk factors act exactly the same for women as men? And then we will target the woman-specific factors that the males doesn't have the same risk factors. Let's start by the general risk factors for both of them. I'm just going to tell you some facts about the situation in the different risk factors. Let's take smoking. We know that smoking is one of the very strong risk factors for coronary artery disease. When a woman quits smoking by the age of 39, she will add 3 years to her life. But when a man quits smoking at the age of 39, he will add 5 years to his life. Smoking in females, in women, have a greater negative effect on the HDL than in men. Smoking has more influence on developing coronary artery disease in females than in men, meaning that if a male and a female, they are both smoking at the same age for the same period of time, say for 5 or 10 years, the woman will have more chance to have acute coronary syndrome than the men of the same age and of being smoking the same amount of cigarettes for the same time. Again, the high blood pressure. High blood pressure is the leading cause of stroke in men and women. Women have more severe symptoms than men with similar blood pressure over the same amount of time. The hypertension is 2 to 3 times more common in women taking oral contraceptive pills than those who doesn't take. And it is more evident in those who are taking contraceptive pills while they are of an age more than 35 years or they are obese. Hypertension has a higher mortality rate in women than in men. Hypertension leads to more heart failure in women than in men at the same level of blood pressure and with the same medication. Again, let's see the epidemiology of cholesterol, which is a very potent risk factor, the hyperlipidemia in women. According to the National and Nutritional Examination Survey data representing the risk factor, the total cholesterol in women from the period from 2015 to 2018, they found that more than 40% of women having total cholesterol level of more than 200. More than this, 12% are having a total cholesterol of more than 240. Those are completely asymptomatic women. They are the normal women in the normal population. 8% of these women having a high density lipoprotein, which is the protective lipoprotein, less than 40. They have more than 30% of them are having an LDL over than 130 milligram per deciliter. the women and men, they tend to have the same level of total cholesterol till the age of 35. And then there is gender discrepancy between both of them. As they advance in age, the women are having more tendency to have higher cholesterol level than the males. With familial hypercholesterolemia, things are different. We used to say that females are having the protection of estrogen till the age of menopause, so they are protected, so that's why the cardiovascular disease appears more in male at this age. And then after menopause, both women and men will have the same incidence of cardiovascular disease. This is totally different in those with familial hypercholesterolemia. If a woman is having a familial hypercholesterolemia, either heterozygous or homozygous, they will lose the protective effect of the female hormones. They will tend to have premature coronary artery disease, and they will have it as at the same age of the men. Let's now see the woman-specific or the female-specific risk factors, which are risk factors related to the reproductive system and the reproductive hormones. Peter et al. 2018 found each of the following to increase the risk of cardiovascular disease in the UK Biobank study population: early age of menarche, early menopause, history of hysterectomy, and among those who gave birth, early age of first birth, or history of miscarriage, or history of stillbirth, all those have a higher incidence of developing premature cardiovascular disease than those who have. And if we try to summarize this, we will find that at the age of childhood, those girls who have early age of menarche or late age of menarche, they are more at risk of developing cardiovascular disease later in life. Again, those with polycystic ovary syndrome, or with infertility, or those who got pregnant and had an adverse outcome of the pregnancy, like toxemia or pretoxemia, or eclampsia, or they had hypertensive disorder, or they have premature preterm deliveries, they are more at risk of developing cardiovascular disease. Again, the later productivity, which is meaning that they had their first baby after the age of 40, they have more incidence of having cardiovascular disease than those who had their first baby earlier in life. Again, lack of breastfeeding. Again, after they develop menopause, they have also risk factors. Those who have early age of menopause, those who have surgical menopause, meaning that they removed their ovaries or their reproductive system early in life due to any disease, or those who had vasomotor symptom severity, those will have more evidence of having cardiovascular disease than others. Again, the cardiovascular disease and the female disadvantage. We discussed the risk factors, and we knew how the risk factors will affect women in a totally different way than in men. Again, there are other factors which is related to the disparities in the cardiovascular disease in both men and women. One of them is related either to person, to the lady herself, and the other thing is that related to us as physicians. So let's see what's the personal factors. I just said now the ladies got the feeling that they are to be responsible for their heart disease, maybe because of their obesity, maybe because of what they did wrong or something like that. They don't tend to admit that they have a cardiovascular disease, and they don't seek medical advice. They have most of the ladies, they has false optimism, as well as the GPs and the cardiologists. They have false optimism regarding the degree of protection of cardiovascular disease due to the estrogen. Women may be unsure of the issue regarding their cardiovascular health. Maybe they have different symptoms. They just don't say, they think that this is normal. Women may be more likely to put their families first and compromise their own health. Usually when we see a female coming to a cardiologist, not to the GP or to the internal medicine, when she finally reached the cardiologist, she already has a progressive coronary artery disease, because they tend to think that this is normal, maybe because she is over tired, maybe she worked too much, maybe she has a lot of physical things at home that she is responsible for her symptoms, but they don't believe that this may be a really heart disease. About professional healthcare factors that we are lagging and we need to increase the awareness about it, we as medical practitioners are prone to the misconception that cardiovascular disease is being a predominantly male problem. Cardiologists are less likely to rate usefulness of the angiography in a female as high. So usually when we have a male and a female, a woman and a man, both of them are coming to the clinic and both of them are having the same complaint, or both of them they had a stress test done. Most of them are positive. We are probably to say, there is a very high incidence of false positive stress test for the female. She is 30, 35. She is not. She's having a menstruation. Maybe she is protected. I will not do any further. I will just give some medical treatment and I will follow up. If the same scenario with a male patient came to your clinic with a positive stress test, on the second day you are going to perform a coronary angiography. And this leads to the late diagnosis of the coronary vascular disease in females. And that's why we are having more problems with females with already diagnosed cardiovascular disease, because we diagnose them a little bit late. The adjusted odd ratio for women being screened for cardiovascular disease risk factors compared to men is 12% less. After adjusting for age, women did worse than men in achieving guideline-based targets of the total cholesterol, of the HDL, of the LDL, of the blood glucose level, and physical activity, obesity, and sending them to cardiac rehab. If the same woman and the same age of the same male coming to you after maybe for primary prevention or secondary prevention, usually they go late. Again, there is also evidence that the treatment given after cardiovascular disease event in women may be less adequately, and we don't give them guideline targeted medical therapy. Just Dr. Jouairia just mentioned this in her presentation. And in the acute setting, physician may miss an acute coronary syndrome because of what is called the atypical chest pain, like Dr. Jouairia just mentioned. And during the late American guidelines during 2019, they just changed the terminology of atypical chest pain. And they came to that, they just removed completely the wording of atypical chest pain in the guidelines, and they say this is atypical form of presentation. There is nothing called atypical chest pain in a female. So we need to raise the awareness of the cardiologists and the internal medicine doctors and the GP doctors. When a female comes complaining, please just don't put the first possibility that she is psychic or she is hysterical or this is an atypical chest pain, because actually there is nothing called atypical chest pain. I just want to give you a small hint about the different presentation of chest pain in women than in men. Usually the GIT symptoms in females are more prevalent than in men. So if a woman came complaining of nausea and vomiting and abdominal pain and cold sweats, and maybe she doesn't have any chest pain, please think of it might be a heart attack. Please just put it in your back of your mind. Or some ladies will come just presenting to you with easy fatigability, shortness of breath. She cannot do her usual activity as she used before. Please don't exclude coronary artery disease. This is a little bit less in males, because more than 60% of males presenting with heart attack will come to you presenting with a typical chest pain. With chest pain in the middle of the chest, radiating to the arms or to the back. They will tell you that they have a heaviness on the chest or squeezing in the chest. So you will diagnose them immediately, and you will just, as physician, our mind is programmed. A male in his late 30s or 40s, he is a smoker, he is complaining of a chest pain. The first thing comes to my mind is going to be that he has a cardiac problem. But in a female coming to you with just shortness of breath, easy fatigability, GI symptoms, pain radiating in her neck or in the jaw, please investigate for coronary artery disease. Okay, Michael.
Thank you so much, Dr. Nareen, for this detailed information. And Dr. Juwairiya, Dr. Nareen has touched base on the dyslipidemia variabilities in women and the different levels of LDL and total cholesterol in women, and especially in familial hypercholesterolemia. So can you give us more highlights into like different clinical trials evaluating the outcomes in women with dyslipidemia, and do women fare better than males in this aspect?
So, I mean, the quick answer is there isn't that many trials looking at women. So women were misrepresented in these trials. So anywhere between 25 and 30% of these trials had women in them. So, I mean, in any of these trials had like anywhere between 25 and 30% women in them. But we know that women are less likely to be on a statin. They're more likely to never be offered a statin, and they're more likely to decline it, and they're more likely to discontinue it. So this is a major problem. So as I said, there isn't specific trials looking at women, and the women are represented less, but there are meta-analyses, multiple meta-analyses actually, that looked at whether women benefit as much as men from statin therapy. And this is one of them, and it shows you that women do benefit as much as men from statin therapy, whether they have vascular disease or not. So we shouldn't deny women statin therapy just because they were underrepresented in trials. On the contrary, they should be offered statin therapy as much as men. Now, the problem here is, I'm sure like lots of clinicians have the same problem. You remember the woman that you had who had an MI and who comes in and now all her body hurts. And she doesn't really have statin intolerance, but she has muscle pain, and you think, probably she's not going to tolerate the statin and she doesn't want to continue on it. So women usually have more statin intolerance. They're more at risk of myopathy, usually have a smaller body size, lower GFR, so higher plasma concentration of statin. They're also more likely to have less adherence to medication because of polypharmacy and because of the social factors that Dr. Nareen spoke about. So women take care of the whole family. They're the primary caregiver of the house. And they have more incidence of depression and anxiety. So they're less likely to adhere to therapy. They're also less likely to reach their goals because of many factors, including having different biology and different lipid metabolism, and having also less chance to adhere not only to medication, but to lifestyle changes. Also, Dr. Nareen mentioned the underestimation of cardiovascular risk factor, and that's also that's a major problem. And also the inertia with physicians, that they're less likely to prescribe statin. So if we're looking at how to treat women with statin, the guidelines do not give you different recommendation for men than women. But something that we always need to keep in mind, that secondary prevention, of course, all women need to be on statin. This is not an issue. The problem comes with primary prevention. And in primary prevention, patients who have familial hypercholesterolemia with a very high LDL or diabetics above the age of 40, or have more than their 10-year ASCVD risk more than 20%, should be on a statin. We're left with a smaller number of, or a significant number of patients who are younger, who have their ASCVD risk less than 20%. And here we have to consider all the other risk factors that Dr. Nareen spoke about. So is there premature menopause or pregnancy-associated disorders, use of tobacco, obesity and diabetes, inflammatory disease? Consider doing calcium score to see if there is coronary calcification or not, and then discuss the issue of using statin in these patients. Of course, it becomes very difficult, especially if you're talking about someone in their 20s and in their 30s. This woman is going to get pregnant, and we're going to have to stop medication and then restart it. So it's a joint discussion between the physician and the patient But it's important that if we decided not to give statin, to give the advice of lifestyle modification and to tell the patient that they have a target. So it's not just lose weight, eat healthy, and goodbye. No, it's lose weight, eat healthy, do this for 3 months, and come back and we'll recheck your lipids. Because that gives the patient more emphasis about how important this is. And if they don't reach their target, then you should consider starting them on statin. So back to you, Michael.
So thank you so much, Dr. Juwairiya. And as we see, there are like lots of disparities and things that are not enabling women to reach their optimal care for cardiovascular disease. And even when we talk about not just the female patients in cardiovascular disease, but the females in cardiology in general, or women in cardiology, we will find that like women representation in cardiology field is very low. Their contribution are like being the primary investigator or the primary author of guidelines or clinical trials is again something that needs to be improved as well. So we need a lot of work to do in the field of the females as a patients and as doctors as well. So would just like from each one of you, if you can summarize from your point of view in like 2 minutes verbally, how do you see it from your side, how we can close the gender gap between men and women in cardiovascular disease, and how we can improve this huge disparities that we have seen in the previous slides. So start with Dr. Nareen.
Again, Michael, I do believe that this has to be a combined work. Just to close this, I want to tell you that at 1990, women were completely excluded from the clinical trials of the cardiovascular trials because it was believed that this is a cardiovascular disease of men. It doesn't affect women, so they are allowed. Though the knowledge have greatly developed since the 90s till now, but still till now we are in 2022, women in the cardiovascular trials, they are only included by 20 to 30, maximum 30% of the population of the clinical trials. So this is one item. Again, we have to raise the awareness of the physicians, first of all. They have to take men a little bit more seriously than before. They have to know that there is nothing called atypical. There is nothing called that because she is a female, she is protected. No, this is not true anymore. So we have to take any complaint of a female just as serious as we take it for men. I do believe that we have to have something like a national program to estimate the lipid profile for all the population in general, putting in men and women, not only for one of the gender. And from this, we can know, each of us, we will know about our population, then the risk factor, because we know that hypercholesterolemia is one of the very strong risk factors of developing coronary artery disease, either premature or mature coronary artery disease. So if we have the national program supported by our governments or something like that at the national level, if we have a lipid profile for all the population, maybe we can do better for our female patients. Juwairiya, what do you think?
So, I mean, I agree with a lot of the points that you mentioned. I see that we can tackle it from different aspects. So we need to increase awareness first among physicians. The risk factors that we spoke about, the traditional ones and the 6 specific ones, we need to make sure that people are aware, physicians are aware of them and understand how important they are and how can they utilize that in managing the patient. We have to increase public education as well. Women need to understand that this is a major problem. Every woman is afraid of breast cancer, but they don't understand that their primary killer is cardiovascular disease. And women, as we know, they're busy with everything. They have multiple hats to wear, and they forget, and they think that, you know, gaining weight is just part of life, and there's nothing you can do about that. So it's very important to focus on these risk factors. You mentioned, we need public policy. We need campaigns to increase awareness about education and research in cardiovascular disease. The Go Red for Women by the American Heart Association is an amazing campaign that has been running since 2004. There is the Lancet Women and Cardiovascular Disease Commission that looks at reducing global burden of cardiovascular disease in women by year 2030. So these are important, and these add a lot to the management, to the health of women. And of course, we need to generate more evidence. We need to generate more literature to address various issues in cardiovascular disease. And this has been in the rise recently from the ESC. There has been lots of state-of-the-art review articles. And there has been more focus, as you mentioned, Dr. Nerine, about generating the evidence in cardiovascular disease in women. So I think these are the main ways to tackle this, to make sure that we, save all the women's hearts.
Yes, that's the right conclusion that we need to reach, is like how to save women's hearts through awareness, through education, through changes in management, through, as you said, the sex-specific data generation. These are all aspects that we will need to tackle to put us on the right track to close this gender gap between men and women in cardiovascular disease. And I see lots of comments in that chat coming from women cheering for this session massively and saying that like this is exactly what we need to hear and this is exactly how we need to approach this topic. So Dr. Joreya, Dr. Nerine, we'd like to thank you so much for all your efforts, for your contribution, and for all your diligent efforts to dig for data. As you said, there are sometimes like very scarce data in this field in so many ways. So on behalf of myself and the whole Organon team, we would like to thank you so much. And of course, we have the opportunity to continue the discussion and the networking lounge for those who are interested to continue with Dr. Nerine and Dr. Joreya. So again, Dr. Joreya, Dr. Nerine, thank you so much for your efforts, for your time, and thank you again for all the whole online audience. And stay with us. We will continue with another session related to hypertension, and we have the opportunity to continue on the networking session with Dr. Nerine and Dr. Joreya. Thank you so much, and have a good rest of the day, everyone.
Thank you.
Thank you. Bye-bye. Bye. So thank you everyone for joining. My name is Michael Sadak. I'm a medical advisor from Organon Egypt. And I'm happy to be your host today for the cardiovascular sessions and specifically related to hypertension. We will start by having a couple of sessions for hypertension that are really interesting. And we have a group of eminent professors and experts with us to talk about it. So we will start the hypertension track with a panel discussion titled Management of Hypertension, How Can We Do Better? And we have 4 eminent experts from the Middle East and North Africa region. The panel will be moderated by Professor Mohammed Radwan Arafa. Professor Mohammed Radwan Arafa is a consultant and interventional cardiologist at Dalla Hospital. He is a fellow of the American College of Cardiology and the American College of Physicians, and he's a professor of cardiology at, again, Dalla Hospital, as I said. So, Dr. Muhammad Arafa, without further ado, the floor is all yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank Organon for their kind invitation for this very important meeting and very important topic. Hypertension is the main killer worldwide, and we have, as I said, very renowned speakers, Dr. Ghazi Radiyah from Emirates, Dr. Muhammad Sadaqa from Egypt, Alexandria, and Dr. Saeed Khudr from Al-Habib Medical Center, and he will try to cover some of the important issue of hypertension management. And I'm going to start by asking our first speaker, Dr. Sadaqa, to tell us about the latest data regarding prevalence of hypertension and its impact on morbidity and mortality. Dr. Sadaqa, you have about 5 minutes, please, to talk about this topic. So please go ahead.
Okay, thank you, Dr. Muhammad, for the nice introduction, and thank you for the panel and Organon for the kind invitation. Actually, I'm going to talk about the prevalence of the hypertension. This prevalence, as you can see, is progressive. We know these data from 1990 to 2019. We have pulled analysis from more than 1,200 population representative studies with more than 100 million participants. The number of people aged 30 to 79 years with hypertension is doubled from 1990 to 2019. As you can see, from 331 million women and 317 million men in 1990, the total number is 648. The total 626 million women to 652 million men in 2015. So these numbers actually is doubled from 648 million to 1.2 billion population having this lethal disease, as we can see this disease. So control of hypertension is a little bit not doing good till this moment, despite of the good quality of antihypertensive medication. Also treated patient not controlled, and diagnosed but untreated representing also more than 20% of the population, and the undiagnosed population representing more than 50% of this 1